الو بسم الله الرحمن الرحيم. السلام عليكم جميعا. Good evening everybody. Today we have I wanted to word anyone going for any exam. Today يعني we have this week we have first Dubai exam, sorry, Oman exam. Result was 50%. And this is one of the worst result for us. 50% Oman, this Edinburgh. So I can tell you it's يعني really most of Oman, I know them, even they attended hands-on, but they did. By the way, we have Samah from Dubai. She's Sudanese. She scored a very high score without hands-on because she's doing practice. This is the first point. Then Lahore, Pakistan, 100%. We have 5 candidates. This 5 candidates passed. So 100% without hands-on. Without hands-on. Then the catastrophe today. Al-Bahrain. One of the worst result in RCSI, our course overall. Al-Bahrain, RCSI. كام؟ Passed from around 25 from my course. وصلت الرسالة؟ طيب.
How many دكتور صلاح؟ أنا ما سمعتش. How many?
5 from 25. طيب. This means what? طيب. Most of people who failed by 1 mark in skills. Failed by 1 mark in skills. صوت واضح كده ولا بيقطع لسه؟
لا كده واضح جدا.
Is it clear for all? طيب. What happened and what will happen? What happened and what will happen? ما تخوفناش. لا أنا هفهمك عشان تفهم هم بيفكروا ازاي دلوقتي. So most of people failed by 1 mark. These people, they put the curve, they changed the curve from first and the second day, because in the first day, for example, many people scored more than 115 in skills. So they put the bus to the curve. So many next day they found not many people scored 117, so they put the curve from 115. يعني هو بيسعى عليك. أنا مش هنجحك. I will adjust the curve according to my mind. So if they will pass 5 only for today, and many of our candidates failed by 1 or 2 marks in skills, by the way, not in knowledge. And these people, by the way, most of the people went for Oman and Al-Bahrain exam. They attend this hands-on in خميس مشيت or in Oman with me. معايا عشان تكون بس فاهمين كده حاجة مهمة جدا. And some people they didn't attend hands-on, they passed. By the way, the highest score from our candidates in the exam in Oman, in Dubai, sorry, in Bahrain this time, she scored in knowledge part 155 from 160. يعني so don't worry, don't panic. And most of people, they failed in skills by 1 or 2 marks, especially communication and professionalism. So what happened exactly in Oman, RCS Edinburgh, and what happened in Bahrain RCSI? This is the first time for RCSI, by the way, Edinburgh, Bahrain exam. By the way, can be changed. Now, the best results coming, it will be in UK. في UK. In UK. By the way. طيب. We have many people, many candidates they pass without hands on, by the way. Just only doing practice. I know Samah, she's doing a great practice and sending for me her videos and she did great. ده رسالة لك انت وهو اللي بتسمع دلوقتي اللي داخل القاهرة who's going for Cairo and who's going for UK. Don't think if I will come for hands on I will pass without doing practice, proper practice, communication, professionalism, you will not pass this exam. They had good evaluation where? Where is the good evaluation? First, good evaluation in Cairo, but I don't know what will happen because they discovered many things bad happened in Cairo. The next good evaluation where? In UK centers. The third good evaluation where? In Malaysia centers. Except RCSI. Take care of these people. I scored in my exam 162 in skills from 200, 162 from 200. Even examiner was greeting me in all skills stations. I did great. But I missed around 40 marks. For what? I don't know. Suzanne was close to fail this exam in skills in Bahrain because of 1 mark only. She passed by 1 mark only. So evaluation of these people, especially RCSI, these people, like I'm joking with you. I saw Irish people, they are having excellent, amazing, pretty girl, pretty Irish. These people are very bad in evaluation. They are very bad in evaluation. Professionalism communication like we are doing now. المشكله في ايه؟ احنا رافعين البروفيشناليزم والكوميونيكيشن. When you are coming for hands on, I discovered all of you are stressful and they wanted to finish from steps only. So try to do practice. When you are coming for hands on, what you should do? All of you, we are dividing the Cairo Center to 2 groups, 2 days and 2 days. So every group will be 8 candidates or 9 candidates within 1 hour. So all of you go and examine and show the admin how you are doing examination. Because most of you, they are sitting, okay, we are listening, we will do. You will not do. You will not do. By the way, other centers in Asia, I have the highest score. Like Penang in August, 9, 8 of them pass, which Shinoda and Maria hands on. Then September in Malaysia with Murad, Sharif, and Makram. We have around more than around 16 or 17 candidates passed from around 22, something like that. This is Malaysia centers. Delhi, we have almost 100%. Islamabad, we have I think 6 from 5, 5 from 6. 5 from 6. Then we have Lahore, 100%. What this means? الناس دي بتذاكر بالعربي كده، الناس دي بتذاكر في السر وبتعمل براكتس، ما بتتكلمش كتير. فهم مش شاكين اساسا فيهم. انت حضرتك داخل لي عامل لي تفرد لي صدرك وعمال تبعت ورقك لده ولده وندخل نذاكر مع بعض ونعمل، كشفوكم في الميدل ايست. خلاص. All people from Malaysia, Pakistan, Bangladesh, they are coming for Dubai or Middle East Center because it has the highest pass rate before. They discovered it now because talking more and more, sharing everything. هقول لك ايه؟ انا حذرت من الموضوع ده قبل كده. حذرت. So what do you think? In Asia centers, all candidates are silent, and going finished. Thanks. Studying, practice every day. الكلام ده موضوع مهم جدا لسبب. انت عندك you have 3 exams at the end of this month. You have 3 centers. Cairo, Kuala Lumpur, and what is else? UK. مع عدد كتير.
دكتور صلاح, you know my experience يعني in practice. يعني my wife, I was practicing with my wife and she knows the examination like her hand. يعني من كتر ما عملنا examination وpractice, وانا registrar and I am working as a surgeon, but this is different. So you have to practice يعني انا مش عايز اقول every day but I did this. يعني every day I was practicing until it becomes يعني a second nature. عشان البراكتس minimizes the stress. يعني الواحد لما بيبقى prepared well prepared ده غصب عنك هيقلل الستريس. يعني in the exam I did not very well in one station, but because I have practiced a lot, I was not stressed in the upcoming stations. So as Dr. Salah said, يعني practice practice practice. يعني ده والله مش كلام اي كلام. يعني انتوا البراكتس every day ده يعني just يعني لو كل يوم 20 minutes يعني practice one station exam one station skills يعني هيفرق جدا في الامتحان. لان يعني هو الهاندس اون ده very useful, the hands on is very useful, but when you are coming to the hands on يعني you have to have يعني practiced before. يعني احنا just modify some points. يعني you can't reach the required level of the skill in 2 days. This is impossible. No one can do this or promise you that we can do this.
By the way, I am in 2 groups for candidates.
لان العدد
بص لا after finishing of this live session, these people they started to share a link and start.
لا بص يا دكتور صلاح، اصل الموضوع مش كيمياء. هو يعني انا بس هستأذنك في دقيقة واحدة. لو احنا عشان to learn any skill ده هو ساينس، انت لازم تبقى عارف النولج بتاعت السكيل الباك جراوند، واحنا بنديهم الباك جراوند دي في الليكتشرز. خلاص. طيب الحاجة التانية ان احنا نفيجواليز السكيلز دي. فاحنا حضرتك في المحاضرات وكده احنا اكسبليند السكيلز دي بتتعمل ازاي والفيديوز. يجي بعد كده بقى احنا دورنا في المرحلة دي بيقف. دورهم بعد كده بيبدا اللي هو يبدا هو يبراكتس السكيل. خلاص. فلما يعمل براكتس السكيل هيوصل للاوتونومي. يعني مع الريبيتيشن اوف ذا سكيل هيجي هو الاوتونومي. يجي دور حضرتك بقى ودورنا بعد كده في الخطوه الاخيره ان احنا لما نشوفهم وهم بيعملوا براكتس بندي جاست الفيدباك الاخير بس. يعني
by the way, if our candidates not clear this exam, nobody all over the world can't pass this exam 100%. So انا عارف انا بقول لك ايه. So
وواضح من نتيجه الجزء بتاع النولج ان احنا يعني الحمد لله قربنا ان احنا ايه نبقى مغطيينه تماما يعني. فانما موضوع
This is more important than our start. This is more important. How to study what we are doing now. How to study this what. So you will do practice in skills. You will do practice in knowledge part. Even knowledge part you do practice. Skills, inshallah, will start after finishing of critical care. We'll go for history. Then we'll go for examination. I will be with you. I will be with you in all live session. Okay, and I will modify as I can. Also, our team, all of them, they are expert enough to modify all your mistakes. Okay, what should you do? What should you do? You should do practice. You should do practice. أنا بعد الناس باخد كلمة كده lightly. Don't talk more in any center. يعني if you are a group going for one center, don't show in exam that you know everybody. Don't take my notes in the exam. Try to keep silent. Don't show that you know the station because this happened in Cairo. What is going, especially in Malaysia and these centers, and Penang, by the way, last 2 days, simply they are going for the exam. It's repeated questions. It's repeated like from the mock. They went, did properly, and left. But in Cairo, no, because of you. So which center I can go? I don't know. Okay, don't worry. Today I have amazing result from Bahrain. If you are studying, doing practice, you will pass. It's very simple. But take care. Don't tell I forget to thank the patient. I forgot to wash my hand. خلاص, don't blame others, blame yourself. If you don't know how to go for the station, smiling, greeting examiner, washing your hands, get more marks by these issues. But no, I will do it in the exam. You will not do it. You will not do it. Okay, so practice properly, you will pass the exam. Many they are going, one told me, I didn't thank any patient. One, I didn't wash my hand. You know, in one exam, one center, examiner told the candidate, you finished? Yes. Do you want to wash your hand? No, I washed before. Oh my God. You want to stick with a mark. Then I feel I want to, what should I do? You failed by one mark. You are the one. You are the one who failed yourself. انا على وضوء من العصر. يلا ابدا يا عم, ابدا يلا ابدا. انا زعلان عشان, by the way, people who failed in Oman, okay, they are not studying properly. But people went for Bahrain, ده فيهم الاول اللي في بارت ايه, ده فيهم واحد كان طالع الاول في بارت ايه على الكليه الملكيه, ده فيهم الاول في بارت ايه, نزل في الاسكيز على درجه. لا اللي حصل في البحرين المره دي قله ادب بصراحه, فخدوا بالكم, خدوا حذركم. يلا.
Okay. Good evening, everybody. Today we have the second critical care mock. So let's start our two participants.
اعمل سكرين كلها.
هو انا يعني انا مش فاهم والله, انا عاملها كلها, مش عارف ايه المشكله.
اقفل وشير اللي هي الكامله, ما تشيرش دي زي المره اللي فاتت.
طيب حاضر, هستوب شيرنج وانا عامل فول سكرين والله من الاول, بس مش عارف برضو ايه المشكله. طيب حاضر, شير فول سكرين. طيب كده.
ايوه كده ماشي.
حاجه عجيبه جدا, ما بفتحها واقفلها تاني بس ما بعملش اي حاجه مختلفه يعني. Okay, so first we have Broma. Please raise your hand, and Mark has excuse me, he won't be able to participate, so anyone from the reserve list can participate. وداد العبدي أو ياسمين أو إسراء, please raise your hands. Okay. Okay, وداد unmute. وبروما. Okay, good evening.
Good evening, Doctor.
Good evening, Dr. Ma.
Are you ready?
Yes, we're ready.
Okay, great. So let's start. Okay, we will select a station for you عشان احنا مش هنمشي organized يعني, as we agreed all. Okay, so we have a 60-year-old male patient with history of old laparotomy. Patient presented with central abdominal pain with vomiting and abdominal distension. You have been called by the nursing staff because he became confused. Okay?
Yes.
So, given the following radiograph, can you see it?
Yes, I can see.
Okay, so what are the findings that you can see?
I can see dilated lobe of small bowel.
Okay. And what do you think might be the cause of this dilatation?
Intestinal obstruction.
Okay. Okay. But يعني just mention كده in few points بسرعة.
Because he had history of laparotomy before, or laparotomy, this may be maybe band ligation or something, making small bowel obstruction.
But just when you are commenting on X-ray, just say, I will ensure that the patient name and the date, just like this, and then start commenting. Okay, how to scan this patient plus this X-ray?
Apart from this X-ray, we can do ultrasonogram. or CT scan of the abdomen.
Yes, with contrast.
Yes,
Okay.
with contrast.
Okay, how would you manage this patient?
This patient I will manage according to management of critically ill patient, surgical ill patients. I will by ABCD. I will start by airway, ensuring the airway good oxygenation for the patient. I will give oxygen 12 to 15 liters to maintain oxygen saturation above 94, and I will start maintaining the breathing.
Okay, what would you do for the circulation?
For the circulation, I will put 2 bore cannulae. I will extract blood for full blood count, urea electrolytes, VBG, and I will give start with resuscitation.
Great. And how would you assess the circulation?
I will assess by general condition of the patient, by pulse rate, blood pressure, capillary refill, and his mental status, and urine output.
Okay, great. If capillary refill was 4 seconds, what does that indicate?
It means that it's delayed capillary refill time. So the patient is in hypoxia or in dehydration.
Okay. How would you diagnose hypoxia?
I can diagnose, sorry, you go.
By pulse oximetry and ABG, arterial blood gas.
Okay. Also, you can say central venous oxygen saturation. Okay.
Yes. Yes.
If he asked for more. Okay.
Okay. Okay.
Next, what to expect in this patient arterial blood gases?
I can find maybe metabolic acidosis with maybe partially compensated or uncompensated.
Okay. And you know why?
Due to formation of due to lactic acidosis.
Okay, because the patient may have intestinal ischemia. Okay.
Yes.
Hemoglobin dropped from 13 grams to 9. What does this indicate?
It indicates either blood loss or hemodilution because of overhydration.
Okay, perfect. What are the factors affecting tissue oxygenation?
Partial pressure of carbon dioxide, pH, or the hydrogen ion level.
Sorry. Again, the factors affecting tissue oxygenation.
This partial pressure of carbon dioxide, then pH, then a concentration of 2,3-diphosphoglyceric acid, the temperature, presence of unusual hemoglobin.
I mean by tissue oxygenation, oxygen delivery to the tissues. What are the main factors that govern the delivery of oxygen to the tissues?
Should I say the equation?
Yes, you can mention the factors and then mention the equation. You have to know the factors. It's
the factors. I think I know that
they are the same factors. Yes, in the main
raised hydrogen ion, or if it is acidosis, then it will raise the oxygen delivery to the tissue.
I'm sorry, you are confused. You are mentioning the factors affecting the hemoglobin affinity to oxygen, or okay. But I mean the factors that affect oxygen delivery to the tissues. One of these factors is the saturation and the hemoglobin, but there are other factors. You need to deliver oxygen to the tissues, so you need cardiac output.
Yes.
It's the same factors which are present in the equation. So you can say them and then mention the equation.
Okay, those are cardiac output, hemoglobin, and oxygen saturation. And
yes,
the equation.
Great. Yes.
And the equation is delivery of the oxygen is equal to cardiac output into hemoglobin into oxygen saturation into 1.34.
Yes, great. So it's an equation and these are the factors. Great.
Okay, thank you.
How oxygen is carried in blood?
It's carried in hemoglobin and some dissolve in blood and some with myoglobin.
You mean hemoglobin?
Hemoglobin
Sorry. You mean hemoglobin? It's bound to hemoglobin, and some is dissolved, not
some is
with.
dissolved, yeah.
Yes.
Yeah.
And not some, it's very few. يعني mainly
Yes.
it's by hemoglobin.
By mainly hemoglobin.
Yes. What are the factors affecting the affinity of hemoglobin to oxygen?
The partial pressure of carbon dioxide,
Yes.
pH, the concentration of 2,3-diphosphoglyceric acid inside the erythrocyte,
Yes.
presence of unusual hemoglobin, temperature, exercise.
What do you mean by unusual hemoglobin?
There may be a fetal hemoglobin or methemoglobin, carboxyhemoglobin, like
yes, great. Okay. So what else remaining?
that. Increased temperature or exercise.
Yes. So it's temperature, because the
Yes.
question was factors affecting. So you say, but only, sorry, temperature, not increased or decreased.
Okay.
Okay. Now the patient regained his consciousness. What would you do next?
I will reassess him. I will do full examination, and according to his status, either he's stable or no, I will do imaging or manage according to his status.
Okay.
Reevaluate يعني.
Okay. So simply you will move to the next step of the CRISP. You made initial management of the patient, then you will do the full patient assessment, and then you said you will decide and the plan.
Yes, this is plan.
So if the patient is stable, what would you do?
If the patient is stable, I will go for investigation, for imaging, for further evaluation, for investigation.
If
like
he's no, if the patient is stable, why would you know? Why would you do further evaluation? You will put a daily management plan.
the management, yeah, daily management
Yes.
plan. Yes.
And if the patient is unstable,
I will go for further evaluation for him and manage accordingly.
yes, great. You need a definitive diagnosis, so you will do further investigations. Okay, so in the full blood count, the mean corpuscular volume and the mean corpuscular hemoglobin concentration are low. What does this mean?
Microcytic hypochromic anemia or iron deficiency anemia.
Okay. And how would you investigate a patient with this kind of anemia?
I will check for serum ferritin and iron binding capacity and stool for occult blood.
Okay, great. Last question. What do you know what are the modified early warning signs?
Heart rate, blood pressure, saturation, urine output, level of consciousness.
Okay, so great. Again, can you say them just for confirmation? They are we have 6 parameters. Again, what are they?
Heart rate, blood pressure,
yes,
respiratory rate, saturation,
Yes.
oxygen saturation, urine output, level of consciousness.
But instead of the saturation, say temperature.
Temperature.
So
Okay.
again, it's a simple bedside scoring index that uses 6 vital parameters. As you said, blood pressure, heart rate, respiratory rate, temperature, mental status, and urinary output. And this was our last question. Thank you very much. You did very well, both. Okay.
Thank you.
Thank you, doctor.
You're
Great,
welcome.
great.
Dr. Salah, any comments?
This station came in recently, I think on last December exam. Okay, the feedback came for they asked about everything in the equation. The factors that asked now exactly by Dr. Murad. What are factors affecting affinity of hemoglobin to or oxygen delivery for the tissue? You should mention the equation. By the way, you have two equation, which is cardiac output multiplied by hemoglobin multiplied by BaO2, or with number. It is the same also with number. يعني ممكن multiply by some numbers. So the factors affecting it: cardiac output, hemoglobin concentration, and
Saturation.
saturation. This is the most important should be mentioned. So ask it in details. So keep the equation because will be asked. Other than this, exactly like previous mock and our book. ماشي.
That's okay.
Okay, great, thank you. So our next candidates, we have Haifa. Okay, Haifa, are you able to participate? She told me that she might not be able. And we have Nidal. Okay, so we have, okay. Instead, we take Yasmin, okay. And Nidal, are you there? Okay, so Isra or Hadir from the reserve list. Okay, so we take Rami instead. Okay. Okay, are you ready?
Yes.
Okay, great. So
Hello, Dr. Murad. How are you?
fine, and you?
Yes, I'm fine. Hello, Dr. Salah.
ازيك يا باشا؟
Great. So our station. Okay. Okay. So you was called at 22:30 for a 45-year-old whose weight is 90 kilograms. Post laparotomy 9 hours ago for a perforated viscous diverticulitis, complaining of abdominal pain. He was conscious, alert, febrile with blood pressure 148/95. His heart rate was 120 beats per minute. The surgical site was normal. Upon reviewing his medication charts, he didn't receive his paracetamol dose at 18. Okay, is it clear? Okay, so can you please tell me what's pain?
Can I go?
Yes, Rom, you can start, anyone.
It's unpleasant sensory or emotional sensation perceived by the brain.
Okay, and it
Unpleasant
must, yes, and it must be associated with
discomfort or tissue damage, sorry, partial
yes,
or
yes, actual
partial
or
potential.
yes, great. Okay, so next question. How would you assess this pain?
For me or Dr. Haifa? Or yes, me to
دكتور
continue.
هيفاء يعني كل واحد فيكم will answer a question. So now دكتورة Yasmin.
Oh, if she isn't here, I can answer this.
Yes.
We can
You can
assess.
answer. Go on.
Okay, we can assess pain using visual analog scale or the numeric scale, or another scale for children is called Wong scale. Don't remember.
Wong-Baker faces.
Yes, Wong-Baker.
Yes. So we have the visual analog scale and verbal numerical scale and descriptor scale. Great. Okay, now I think we have Nidal. Are you here?
Yes, I'm here.
Yes,
Assalamu
welcome. Walaikum salam. Okay, so next question for you.
Yeah.
Okay, so given this vase, do you know what does it mean?
Yes, visual analog scale.
Okay, great. So given this vase, what does it tell?
6. This is moderate.
Okay, great.
In exam, yes, in exam he will ask you mild or moderate, يعني not 6, يعني it will be يعني if by this way, because they have another analog in exam, not this scale.
They are different. There is this one with numbers from 1 to 100.
This not with numbers. One coming with mild, moderate, and severe. It will be moderate for sure, يعني 100%.
Yes. Okay,
Yes.
so considering VAS and patients prescribed analgesia, what are the instructions you will give to the nurses?
First of all, I will confirm the missed dose of the paracetamol, and I will try to give him this missed dose. If he improved, that's okay. If he isn't improving, I will give him a dose of opioids, mostly morphine, of about 5 milligram intravenous or subcutaneous. 10 milligram
Okay.
intravenous or subcutaneous or intramuscular. If he improved, that's okay. If he doesn't improve, I can add non-steroidal anti-inflammatory drugs to the opioids.
Okay, so you said right, but I would prefer if you follow the WHO step ladder. So you said you will give the patient 1 gram paracetamol, then you will give the patient, if the patient started oral, you will give non-steroidal, and then you will give opioids, as you said, morphine. Okay.
Okay.
Okay. So if the patient's pain failed to settle, what would you do, Nidal?
I repeat the dose of the morphine, call anesthesia for help, and reassessment also examine the patient to check any cause can lead to this pain.
Yes, you're right. And I would like to stress this important step. You have to say, I would examine the patient to exclude any surgical complication. Okay, like this. It's very important. Okay. Great. What do you know some side effects for post-operative pain?
Yes, it may cause tachycardia, may cause hypertension, may cause inhibition of the cough reflex and the collection of secretions in the lung, causing atelectasis and pneumonia.
Okay, what else? Always classify. You said what you said is right. So on the center, on the cerebral, in the cardiovascular system, you said that it increases the heart rate and myocardial consumption. It may cause DVT. Okay, right. And the respiratory, you said limit chest movements. And what other systems would be affected?
I think the GIT also may be affected, causing ALIAS.
Yes, great.
Limited mobilization of the patient, which has very deleterious effects, including delay in regaining peristalsis or
okay, great. So and also what it increases the stress response.
Yes,
and
increases stress.
Do you know any effects on the CNS?
Anxiety, agitation.
Yes.
Decrease cooperation. Yes.
Yes, perfect. And the sleep disturbance. Great. So, what are the potential side effects of opioids when used post-operatively? Nidal.
Potential side effects of opioids as the post-operative analgesia. Yes, side effects can lead to respiratory depression, nausea, vomiting, constipation, also seizure, and this is in post-operative. So
yes, in general, it may cause also itching. Okay.
Yeah, itching. Yeah.
Decreased level of consciousness. But it's great that you started with the important one, respiratory depression. Okay. So, Rami, can you please describe the pain pathway from the receptors up to the brain?
Okay, we have sharp pain can be transmitted via the fast A delta fibers, and the slow pain can be transmitted via C fibers, which is slow for slow pain, and this will be transmitted to the dorsal horn cells as a first order neuron, and then the second order neuron will cross to the opposite side and ascend via the lateral spinothalamic tract to relay in the hypothalamus. Then after that will reach to the post-central gyrus in the cerebral cortex.
Yes, okay. You said it will ascend to the thalamus, not the hypothalamus, okay?
I think yes.
Yes, thalamus.
Thalamus, sorry.
Yes. Then the somatosensory cortex and the post-central gyrus, as you said. Great. Okay, so patient pain failed to settle and anesthesia recommended PCA device. Can you tell me what are the features of PCA? First tell me what does it mean, Nidal, PCA?
This pain, bus. You want to this?
You don't know what does it mean, PCA?
No, but no, but I'm not recall this proper.
Okay, Rami, can you answer?
Yes, the patient-controlled analgesia is composed of a syringe pump. It has a look-out time. Usually, it's about 5 minutes. The patient presses a button to deliver the required dose of opioids. Usually, it's about 0.5 milliliter, which is equal to 1 milligram of morphine. And the lookout time usually prevents the overdosing when the patient presses on the button for multiple times. And
it has also
yes.
It has also a one-way valve, okay,
yes,
to prevent backflow and overdose. Okay,
can be programmed to meet individual patient needs and help us in studying the effective dosage for each patient.
Okay. Can you tell me what are the potential problems with using this kind of analgesia? Do you know, Nidal, or?
Yes, pumping failure also can lead to sleep disturbance, and this is difficulty in use. The inpatient has a loss of consciousness or confusion. Also, there is the broken like any instrument.
Okay. So you said pump failure. We have also failure of the IV set itself or failure of the one-way valve. Okay. Complications to the patient, as you said, sleep disturbance, and needs the patient to be alert to be able to use it, and it limits the mobility also. Okay, what are the types of opioid in common use?
We have natural opioids or non-synthetic opioids such as the morphine and codeine, and have a semi-synthetic such as dihydrocodeine, and we have a synthetic such as the pethidine and fentanyl. Morphine for the semi-synthetic.
Okay, great. What are the mechanisms of action of paracetamol?
Yes, paracetamol, it is a weak inhibitor of the prostaglandin and the COX-2.
Okay. This is right, partially right, but you have to say that paracetamol is analgesic and antipyretic. Its mechanism of action is not totally understood, but it's thought to be, as you said, because no one knows exactly what is the mechanism, but it's thought to be inhibitor of prostaglandins. Okay.
Yeah.
Okay, great. So I am saying this to make your answer personalized, not like everyone else. Okay. How to manage paracetamol toxicity, Rami?
If the patient come in the first 60 minutes, we can do gastric lavage. If he come during the first 30 minutes to 2 hours, can give him activated charcoal, and we will manage him according to the care of critical surgical patient to ensure that the vital signs are good, airway breathing and circulation. And in final stages, if he had a liver failure, can proceed to liver transplantation.
Okay. Do you know any medications that
yes,
can
yes.
be given to this patient?
N-acetyl salicylic acid. N-acetyl salicylic acid will be given as an antidote, which helps to replenish the body stores of
Okay.
glutathione.
So you will give the patient aspirin. Okay, you said that you will give the patient salicylic acid.
N-acetyl.
N-acetyl what?
N-acetyl salicylic. N-acetyl cysteine, sorry.
Cysteine. Okay, this is important in the exam. You may say a wrong word and he will take it.
Sorry.
Okay.
Yes.
Okay, this is the end of our exam. You did very well, both. And Nidal, you have to study BCA.
Okay.
Okay, man, but you did great. Thank you very much. Dr. Salah.
Okay, in critical care, you have 4 marks for professionalism, not like pathology or anatomy. Nidal, he will pass the question, but will give you 0 from 4 in professionalism. You see,
Thank you.
it's easy, pass the question, but he will not get the professional marks. So don't think that you will miss this.
When I take some time to just modify some answers, as I said, to make it personal.
The worst thing in knowledge is critical care. Why? Because this depending mainly on your understanding. Go back and answer back اللجنة التانية. Go back. ده عايز الاستثناء.
اللي هو اللي قبلها
البين لجنة البين.
اوكي اهي. سوري.
Okay. By the way, the timing not 6 p.m. as written in the STEM, it's written 10 p.m. Why? The big difference. Because in management of the patient, considering prescribing analgesia, what is the instruction you will give to the patient or to the nurse? Instruction will be given to the nurse. You answered exactly. You will give now 1 gram paracetamol, and the omitted dose should be given on time. Don't inform pain team. Yes, because it's 10 p.m. You will start first to manage the patient. Then, if pain not settled, you will go for giving more morphia. Inform the pain management team or anesthesia on call, and look for any underlying cause. Okay. Other things like you discussed exactly, nothing more. By the way, the answer of this station already in the notes group. Rahil, he wrote everything. مكتوبة لكم. مكتوبة لكم.
وعلى فكرة أنا بس I need to stress this station is written most of the information are taken exactly like in the CRISP manual. عشان نبقى احنا we are very sure from the information. It's like this in the CRISP manual of the Royal College. Okay. Okay, Dr. Salah. Next we have
I think in Cairo, before this station came, about what is the complication of pain. In the mock, I told some complications. No, in Cairo, he's asking the details of complications like our book on system. Complication of pain, according to the checklist, like I told in the lecture, very easy. But in Cairo exam, last December, not December, previous one, he asked about complication of pain on every system. So once you will get this question, when asking you complication, tell pain can affect the cardiovascular system, GIT system, nervous system, respiratory system by 1, 2, 3, 4. First, give titles, then start by system. Okay.
Okay, thank you, Dr. Salah. Okay, so next we have Nurhan and Abdurrahman Al-Gizawi. Okay, Nurhan and Abdurrahman. Okay. Okay, Nurhan, please raise your hands. عشان I can't find you.
تمام احنا مع بعض في نفس المايك.
طب حلو جدا. اوكي كويس. توفيق.
ازيك دكتور مراد، دكتور صلاح، how are you doing؟
الحمد لله. انتوا كويسين؟
الحمد لله.
Before going, sorry. The feedback came from these two stations about how to optimize cardiac output, factors affecting oxygen saturation. اللي جاوب اللجنه دي how to optimize cardiac output or how to increase cardiac output. اللي كانت اللجنه الاولى كانت وداد. طيب لجنه البين مانجمنت it was visual analog score not faces with a marker just after the mid line. Okay, I think all the questions like we discussed. I told him look for complication post-op, requested abdominal ultrasound, accepted that although the stem started possible complications.
انا قلت لحضرتك complications دي surgical دي very important to be mentioned. لما اجي اسس البين ان انا اقول I will look for any surgical complication.
يعني yes, in cardiac output I have picture في بتاع الصوره بتاع cardiac output I have very nice picture for it. How to increase cardiac output by you should first start by what? How to optimize cardiac output. Tell the equation cardiac output equal stroke volume by heart rate. صح كده؟ stroke volume by preload so in venous return and stroke volume also by contractility of the heart by giving the patient can be inotropes and stroke volume also by afterload which is contractility. I think you should mention how to optimize cardiac output. Start by the equation first. هبعتها لكم دي. I just remember this question.
صح لا great answer. همنشن الاول الكاردياك output depends on what وthen how to increase each of these components.
تمام. This is updates with inotropes, increasing contractility of the heart, increase the preload afterload. تمام. انا هحط لكم المعادله ديت. يلا اعتقد كده ايه اللي بتقدر الابديتس بتاعتهم اللي جم في الاخر خلاص كده.
Great.
يلا.
Okay, Abdurrahman and Nurhan, are you ready?
Yes.
Great. Okay, so we have a 40-year-old lady, post total thyroidectomy for follicular thyroid carcinoma. Post-operative day 4, her serum calcium came and it was 0.7 millimole per liter. So first question, how to calculate the corrected calcium?
The corrected calcium level can be calculated via adding 0.8 to the total calcium in serum.
Okay, so can you please tell me what do we mean by corrected calcium?
It's the amount of calcium bind to albumin plus the total free calcium in blood.
Okay, so you said the equation but you missed the part. That's why I asked you this question. So corrected calcium means the calcium in relation to the albumin. Okay, because if albumin decreases, this will decrease the calcium. I mean the level of the free calcium. So the equation, as you said, would be the measured total calcium, the actual total calcium plus 0.8, but this would be multiplied by 4 minus the serum albumin. Okay, so you have to mention the serum albumin because you are correcting it in relation to the albumin. Okay, so next question, what's the cause of post-thyroidectomy hypocalcemia?
Either removal of the parathyroid gland or ischemia to the parathyroid gland due to injury of inferior thyroid artery.
Great, thank you. Next question, how the calcium is transported in blood? Abdurrahman.
So the calcium, 50% of the calcium is unbound and ionized, circulating freely in the blood. 45% of the remaining calcium is bound to plasma proteins, which is albumin, and 5% are associated with anions such as citrate or lactate.
Great. What are the rules of calcium in the body in general?
The calcium is important for neuromuscular transmission, for smoothing skeletal muscle contraction, for cardiac muscle contraction through binding to troponin, mineralization of bone, blood coagulation, factor in blood coagulation.
Yes.
Mm,
Okay. We have.
mediation of
Yes. Okay. Go on.
mediation of the cellular response to numerous hormones.
Okay, like cyclic A and B. That's right. Okay. Okay. So I think we, Dr. Salah shared even the explanations of these functions. Sometimes they ask about it, like the release of neurotransmitters and hormones, how it happens. Okay, but you answered right. Okay. What are the hormones involved in calcium homeostasis?
We have three main hormones involved in calcium homeostasis. They are parathormone, vitamin D3, and calcitonin. The parathormone, it acts on two stuff. The first, it acts on the bones, increasing the synthesis of enzymes that break down the bone matrix to release calcium. And it acts on the kidneys, which increases the renal phosphate excretion, which stimulates the alpha-1 hydroxylase activity in the kidneys, which increases the vitamin D3 absorption.
So it increases excretion of phosphate, but decreases or increases reabsorption of calcium also from the kidney.
Yes.
Okay.
And
okay.
vitamin D3 itself, it acts on the bones, increasing both increasing both calcium calcification of the bone matrix and simulating also osteoblastic activities. And on the GIT, it enhances the absorption of calcium from the ileum. Calcitonin,
and the action on the kidney.
I think it promotes calcium and phosphate reabsorption.
Okay, great.
Or the calcitonin, it acts on bones and kidneys. The bones, it inhibits the bone resorption, and the kidneys stimulate the excretion of sodium chloride, calcium, and phosphate.
Okay, that's great. But just mention that parathyroid hormone increases calcium. Okay. And calcitonin decreases calcium. This is the main action, and what you said is right. The mechanisms. Okay, so how vitamin D3 is formed?
Okay, vitamin D3 is formed through the exposure to sunlight. It will change the dihydrocholesterol into 7-dihydrocholesterol into pre-vitamin D and calciferol, and then it goes to the liver, where 25-hydroxylase enzyme change it into 25-hydroxylase cholecalciferol.
Hydroxy, not hydroxylase. Hydroxy cholecalciferol. Okay.
Cholecalciferol.
The enzyme is called hydroxylase, and the compound will be hydroxy cholecalciferol. Okay.
And then in the kidney, it will be changed into 125-dihydroxy cholecalciferol through 1-alpha hydroxylase.
Okay, perfect. Thank you. Okay, next question. What are the signs and symptoms of hypocalcemia?
Okay, the signs of hypocalcemia. Neurologically, the patient is going to be irritable, and he's complaining of muscle cramps. Patient can go into tetany, and the patient may have chopstick sign when tapping on the facial nerve. And he may also have circumoral paresthesia. and the patient may have trousseau sign, where we increase the cuff blood pressure above normal.
No. Tell the signs only. Then we'll ask you what is the rosy sign.
Look,
Start to explain.
I will كمان يعني هو بيشرح بس it's better to say
هو
the
عارف السؤال
symptoms
اللي بعده. لا هو عارف السؤال اللي بعده. هو يبين عارف السؤال اللي بعده.
بالظبط ما عشان
The
كده
symptoms are the signs only. He will ask you what is the rosy sign and what is the sign.
يعني
ما
يعني
المشكلة ان هو بيقول signs and symptoms.
Okay.
but I didn't ask about the explanation.
هو سألك.
So you can say the symptoms like you said, tetany, spasm, circumoral, and then the signs, chavostic and trousseau sign, just like this. Okay. Then I may ask you, can you please explain to me chavostic sign, for example? Okay.
Chavostic sign.
No need. You already said it, but I'm just explaining. So in general, guys, when you ask the question, just say the points, the main points for the time's sake. Then if he would ask you, okay. So which muscle are you worried about in tetany?
The laryngeal muscle. I'm worried about laryngeal spasm.
Okay, great. What are the ECG findings in hypercalcemia?
Hypercalcemia.
Yes.
اقول انا ولا تقول انت؟
لا ما انتوا ما تتخانقوش بقى. اي حد.
طيب ECG findings in hypo and hypercalcemia.
I said hypercalcemia. I haven't mentioned hypocalcemia.
والله الاستمع اهو hyper and
ماليش
hypercalcemia.
دعوة. I said hypo. I said hyper. Focus on the question.
Okay, hypercalcemia. We have shortened ST and QT segments. QT interval and ST segment.
Okay, so it will be short QT interval. Okay, due to short ST segment. Great. And what happens in hypocalcemia? Now I'm asking.
In hypocalcemia, we have lengthened ST segment and the QT interval, which may cause torsade de points sign.
Okay. In hypercalcemia, there may be also signs similar to hypothermia, like Osborne waves. Okay.
What's the name of the waves?
Osborne waves.
Osborne waves, like what happens in hypothermia, but this is in severe cases.
اللي هي الجي
yes.
الجي ويف صح؟
Yes. But this is in severe hypercalcemia. Okay. Can you please tell me how to treat hypocalcemia?
According to CRESP protocol, according to the care of critically ill patient protocol, I will start with the cardiac monitoring through ECG. We'll do fluid resuscitation with Hartman, and we'll give 10 ml of 10% calcium gluconate IV, followed by 10 to 40 ml of calcium gluconate in saline infusion over 4 to 8 hours. And we'll still monitor for hypomagnesemia and the saturation.
Okay, so we will give the patient calcium gluconate, as you said, okay, and we can repeat the dose, okay, if needed. And we correct, not monitor, we will correct any hypomagnesemia, okay? And then after this, we will give the patient long-term calcium, okay? So in the acute stage, as you said, but this is only in the acute stage. But after
Dr. Murad, sorry for interrupting. Is he going to ask for the treatment of hypomagnesemia itself?
No. But it's very important for the action of calcium to correct magnesium. Okay. Thank you. Great. So why this patient or patient with hypercalcemia could develop abdominal pain?
Because of the developing of peptic ulcer.
Yes.
pancreatitis, or maybe renal stones.
Okay, thank you. Okay, how renal failure could cause hyperparathyroidism?
Renal failure causing hyperparathyroidism has when the patient has chronic renal failure, the patient has decrease in 125 dihydroxycholecalciferol, which decreases the calcium absorption from the intestine, and with the decreased glomerular filtration rate, the patient will have decreased phosphate reuptake. So, sorry, increased phosphate reuptake and decreased phosphate excretion. So the serum phosphate will increase, and then the serum calcium will decrease. Therefore, the decrease in serum calcium will cause an increase in parathormone.
You have explained perfectly, but يعني don't get confused. There will be a hypocalcemia and a hyperphosphatemia at last, يعني. And this will cause which type of hyperparathyroidism?
The second type, secondary
Yes,
hyperparathyroidism.
Perfect.
By the way, can cause secondary or tertiary.
طبعا ما هو after this can cause tertiary طبعا. Yes.
في بارت ايه you have some question بس انتوا اساسا ناسيين مذاكرهم امبارح هتفتكروا بتاع بارت ايه يلا. So no transplant long standing يعني okay so secondary, and if you have long standing renal failure can cause tertiary by the way. طيب go back for this station Dr. Murad. I have some questions. This station came in Penang 2 days ago. It was exactly and not going deep, just these questions, and it was concerning about the sign, Jovistic sign, and it was the signs. Rule of calcium I shared in the group, asked once only in Cairo before Corona. Rule of calcium in your body with explained in details, like I shared and I discussed with you before. Asked once only in Cairo before Corona, like calcium required in muscle contraction, how to do it. Calcium needed for nerve conduction, how to do it. For blood coagulation, how to do it. For hormone release, how to do it. Okay. So for hormones, and intracellular calcium level are much lower than the extracellular due to relative membrane impermeability. Yeah, you should explain.
The for nerve. It's rule for nerve.
For neurotransmitter.
Yeah.
So please read this only for your knowledge. You don't know what will happen. Okay. Last update for this station. هو الصوت مش واضح ولا ايه؟ ليه تاني كده؟
لا انا سامعك.
الصوت واضح يا باشا.
طيب.
It's clear يعني.
دكتورة نورهان.
ايوه.
What's the effect of parathormone hormone on calcium? In details.
Okay, parathormone hormone acts on bone to increase the osteoclastic activity and therefore increase the serum calcium. As for and acts on the renal tubules to increase the phosphate excretion and reduce the calcium loss to increase the serum calcium.
You told in the kidney and in the bone and in the intestine?
Increase calcium absorption from the intestine.
Sorry, Dr. Salah, I'm sorry. So parathyroid hormone acts on the intestine?
How?
Does it act directly on the intestine, Dr. Nurhan?
Actually, I don't think so.
أيوة.
But
when it asked
طيب okay. Let us answer this question. On the kidney, how parathormone hormone increase calcium level or affecting parathormone hormone on the calcium? On the kidney, parathormone hormone increases the calcium reabsorption and blocks phosphate reabsorption from the tubules. So also parathormone hormone acts at the kidney to stimulate formation of vitamin D or activation of vitamin D. Okay, and as you know, vitamin D is essential component for calcium and phosphate homeostasis. Okay, this on the kidney. On the intestine, parathormone hormones seems to act indirectly on the intestinal calcium absorption by stimulation of renal 1-alpha hydroxylase. So it will increase the active form of vitamin D, which is 1,25
hydroxycholecalciferol.
which is the active form of vitamin D, which enhance absorption of calcium on the intestine. Plus, on the bone, it increases the calcium level by increasing osteoblast, increasing osteoclast, increase in bone formation size, and increase calcium efflux. He's waiting this answer, by the way. Okay. Other than this, all the questions are the same. Calcium station, very nice station, by the way. It's a very nice station in your exam. Only they want to parathormone hormone in details, like we did, and the rule of calcium better to read it because asked once only in Cairo before Corona. تمام? No more questions. يلا.
Okay, thank you, Dr. Salah. Okay,
Thank you, Dr. Salah. Thank you, Dr. Murad.
thank you, guys. Well done. Okay, so now we have عدنان و والله يعني. Okay, عدنان, and please raise your hand, عدنان. Okay. Okay. Great. And
hello, Dr. Murad. Hello, Dr. Salah.
oh,
مرحبا. ازيك يا دكتور؟
okay. And we have Saeed. Sorry, we have Hussam instead. Sorry, I'm sorry. هو دكتور سيرجن ده means Hussam or what? Okay. Okay. Hello. Hussam, are you here?
في answer to raising hands.
أنا مش
سعيد.
عارف هو I'm asking him to unmute بس هو ما بيعملش unmute. Okay. So سعيد
خلاص
و
اسكت unmute. يلا يا ابني افتح المايك بتاعك.
يا كبير معاك.
وعدنان. عدنان, are you here?
Yes, yes, Doctor.
Okay. يعني مش عارف ليه we are losing time. Okay. So next station عشان بس نبقى يعني to know who's next. I have shared يعني we have أحمد علي and Rami Salama. Please raise your hands عشان تبقى ready يعني. Okay. So we have okay. So you are the SHO on call and have been called to surgical HDU to review a 60-year-old male who underwent anterior abdominoperineal resection under general anesthesia 12 hours ago. You didn't attend operation and didn't see him before. The nursing staff are concerned about his low urinary output. Physical examination was unremarkable and the catheter was patent. Upon reviewing his fluids and observation charts, he was NBO and he received only 1 liter of fluid over the last 12 hours.
Yeah, okay, before going for this station. This this was my statement in the field. And this is one of the nightmare situation for me, as I remember. I don't know what he's asking about. I think I went in knowledge going properly. I'm not stopping in any question. I'm going till I reach this station. Examiner was very bad. When I started to answer, okay, he giving in front of my eyes, big X. Next question, ask big X. I took in the first paper asking from the first paper, he's asking all X. Then I started to put my eyes down. I thought, okay, at least I should score some marks in this station. I will not look for this stupid man, what he's doing. So he started to ask me, I'm not looking for what he's writing. I started to answer the questions about physiology. And I know this one of the worst stage. This came also for Suzanne in البحرين.
دي جات لي يا باشا برضه في القاهره برضه الدور اللي انا كنت دخلته السنه اللي فاتت ده.
لا مش دي. Lastly ما جتش في القاهره لسه. Lastly this is I get the checklist of it. So now Dr. Murad will discuss with you from the checklist. When I discuss this station for all candidates, especially the lecturers, they told me, Dr. Salah, we can't understand anything. Don't worry. Go for the exam and do what we are doing now, and you will get the full mark in this station. يلا ابدأ يا مراد.
Okay, so on light of the fluids and observation charts, what is the likely cause of this low urinary output?
Is usually it is maybe due to decreased glomerular filtration rate, due to decrease in blood pressure, and maybe presence of decreased fluid resuscitation.
Okay, so you have answered right. You mean the patient is hypoperfused because the patient have not received enough intravascular
volume decrease due to decreased supply. Yes, resuscitation
yes.
or
yes. Okay, I'm just organizing the answer. So the patient, from the chart, the patient is hypotensive and tachycardic, okay, because he has reduced intravascular volume, most probably due to inadequate fluids. Okay, so, but you answered right, by the way, and you understand. What is the appropriate management of this patient?
I will start fluid challenge by giving 250 milli bolus or 10 milli per kg and monitor the response of the patient.
Okay, first, what type of fluid will you give this patient?
Crystalloid.
Okay, and fluid challenge, how much?
250 milli bolus or 10 or to 20 milli per kg.
Yes, because this patient is hypotensive. So it's
Yes.
better to mention the number 20 ml per kilograms. We give 10 in normotensive patient. This is the fluid challenge. 20 if the patient is hypotensive. And if the patient is cardiac, we give 5 mLs. Okay. So what is the
دكتور معلش لو بيشنت كاردياك بدي كام؟
5 milliliters لان انت بتبقى cautious to avoid doing fluid overload and pulmonary edema.
By the way, in crisp book, this is written 5, 10, 20.
طبعا ما انا من كريسب
انا ما دخلتش الكريسب اول ما خدتوش بس بكتب لكم ايه.
صح يعني perfect يعني it's written as Dr. Salah said يعني.
قولها لهم دي يا مراد، قولها لهم.
ما هي 5 if the patient is cardiac we give 5 to avoid volume overload and pulmonary edema. If the patient is normotensive, because we may give it to a normotensive patient, we give 10 mLs. But if the patient is hypotensive, you give the patient 20 ml per kilogram. Okay, so
that's great.
Yes. So the patient is monitored every 2 hours. Is that adequate?
Yes. No. Yes, it is adequate every hour. Yes.
I said every 2 hours.
No, so he should be monitored every 1 hour.
Okay, great.
Which number 3 you told it?
Sorry, دكتور صلاح. قلتها لهم انت ما سمعتهاش اللي هي انت بتتكلم على الفلويد ريبليسمنت.
No, it's the most important question. Question number 3.
Okay. Yes, I'm sorry. So what are
اسمعني. الراجل لما سألني السؤال ده when he asked me this question he told what is the rationale, what is the theoretical physiological rationale. I told what he's talking about.
هو على فكرة by the way anyone would do the same يعني.
يا باشا اذا احنا كنا مذاكرينها ودخلت عملت زي ما حضرتك بتقول كده.
The question will be asked by this way.
بس والله اللجنه دي جات لنا في القاهره.
ايوه صح افتكرت صح فعلا.
So what are the theoretical physiological rationale for giving the fluid challenge rather than speeding the drip up?
Me?
Yes.
Okay. Giving the fluid challenge has both diagnostic and therapeutic cause, as according to Sterling law, giving the drip within directly to heart, it goes tension of cardiac muscles according to Sterling law, and the increase in the systolic volume will cause myocardial stretch, and increase contractility and increase cardiac output. Giving slowly fluid will don't know make this effect, as will not stretch the left ventricle, so will not give any information regarding the cardiac case.
Response. You mean the cardiovascular response? Okay.
Yes, cardiac response. Okay.
Okay. Perfect. This is the right answer. Great. The most important is to mention Sterling law. Okay. So the patient is monitored every 2 hours. We said we answered this one.
Once you will tell Sterling law, and this is also therapeutic and diagnostic for you also to know, especially the cause and the Sterling law, I think it's going to be satisfied here.
Yes.
Yeah.
Yes. Are there any reasons why synthetic colloids are not advised in post-operative patients?
Yes, there is no evidence of benefits over crystalloid, and also it's more expensive, and starch increases mortality in sepsis, and also the risk of the anaphylaxis.
Yes, risk of anaphylaxis and coagulopathy. Okay.
Before going, do you think you are a surgeon? Yani the question asked by this way, and you tell no evidence for that, so you search it everywhere. يا ابني كانت اللجنه انا بتفكرني خلص انا كل ما بشوف سؤال بقى، كل ما افتكر اللجنه ديت بيتقلب عليها المواجع. يلا.
باشا هم they thought that everyone has taken the crisp.
They are lucky. You know why? Because we get the checklist. We get the checklist.
يا باشا حضرتك كنت قلت تقريبا ممكن ندي القلب من في الحالات اللي زي دي، صح؟ في الحاله دي.
ايوه ممكن.
But don't mention it. Okay. How are you going to manage this patient circulation for the remainder of your shift?
Okay. At the first, regular review of blood pressure and other clinical signs, capillary fill time review, repeated fluid challenge, and inform the nurse to contact me if there is any problem, and reassess the patient from the start as to search for any problem that may be present, like occult hemorrhage or something like this.
Okay, great. Okay, so assuming that the patient becomes more hemodynamically unstable, and you give him more fluids, what are the means to assess CVS function and the patient response to therapy?
By do minimally invasive cardiovascular monitoring by arterial line, and transesophageal Doppler, and also lithium dilution cardiac output monitoring, and pulse control analysis.
Okay, these are both the minimally invasive.
Yes,
okay?
lithium and the pulse.
Yes, and we have transesophageal Doppler. Yes, right. And rarely we use CVB monitoring. Okay. Great. Dr. Salah, I just want to add, because it's always mentioned in the CRESP about this question we have answered. They sometimes ask it like, if you are not sure about the cardiovascular or fluid volume status of the patient, it would be the same answer. We will do the monitoring like you said. Okay. Yes.
احنا ممكن نزود يا باشا الترا ساوند اون انفيرور فينا كافا.
لا
لا زي ما مكتوب بالظبط.
هو ده اللي مكتوب على فكرة حتى في الكريسب يعني. This is exactly the same. Okay. Who to notify about this patient status and when?
I'll inform my consultant and update him about the case if there is no response for multiple fluid challenge.
Okay.
About 3.
About what?
3, yes or what?
3. What do you mean by 3?
I'll repeat the challenge for 3
Up
times.
to 4. Up to 4. Okay.
Okay.
Can you please tell me what are the hormones expected to be secreted in an attempt to preserve circulation or
Yes,
circulatory volume?
Renin and aldosterone, also the antidiuretic hormone, cortisol, and the adrenal corticotropic hormone. Also
Yes,
growth hormone.
yes, this is enough. The most important antidiuretic hormone, aldosterone and cortisol. Okay, where is antidiuretic hormone produced and what are the factors that stimulate its secretion?
At the first, it's produced in by hypothalamus and stored in posterior pituitary gland. Then it is secreted in response to some factors. The most important is plasma osmolarity and hypovolemia, hypotension, and angiotensin II,
Okay.
and some drugs like nicotine.
Okay, so as you said, the most important, the increased plasma osmolarity, reduced circulating volume, and angiotensin II. Okay, where does it act? I mean antidiuretic hormone.
On the collecting duct.
Okay, thank you. Great.
معلش يا دكتور مراد، هو الانتي دايوريتيك هرمون اللي انا قريته ان هو كان كونتاكت ويز ريسبتورز اون ديستال كونفوليوتد تيوبول، هل هو كده بيشتغل عليه بالظبط؟
على الاثنين، بس مين
على الاثنين.
السؤال ده جاب بارت ايه؟ يو هاف تو اوبشنز، انتيدايوريتيك هرمون وركينج وير، كولكتنج داكت ولا ديستال كونفوليوتد تيوبول. wait no junction, you are meaning about aldosterone, you are talking about aldosterone. يا زكي اهدى شويه. antidiuretic hormone working both by the way, but in exam when came in part A, both of them. So I have evidence, by the way, I can share it for you, working mainly in collecting duct and in the checklist written collecting duct. Okay.
خلاص احنا عندنا الشيك لسه يا باشا، ماشي.
So يعني very nice when I ask you about the colloid you will tell no evidence to give this. لما كلكم كده 50 واحد يقول له ادخلوا no evidence، العيال بتقرا evidence ظبط اجابتك.
لا بس هي مش مشكله، بس خلوها اخر واحده، هي it's written in crisp يعني ان no evidence. فانتوا لو if asked how do you know this it's written in crisp. اوكي يعني اي حاجه تزنقوا فيها.
انا عارف يا باشا انا عارف هيعملوا فينا ايه. هم هيجيبونا الارض قريب، هم خلاص، لان مفيش ذكاء في التعامل في اللجان، مفيش ذكاء في التعامل. يعني so if difficult question and the answers is different like theoretically no evidence for that، وكله دخل قال نفس الكلمه
زي بتاع ده يا باشا الكرات بلو اب دي ولا بلو اوت دي؟
بلو اوت.
بص يا شباب، اللي هيكون ذكي في التعامل في الامتحان ده هيمشي، اللي هيحفظ ويدخل يقول معلومه كده هيلبس في الحيط. هم they are starting to attack you, they are waiting, you are keeping information or you are expressing from your mind from your knowledge. تمام كده؟ كنا مذاكرين ايه؟ according to صلاح and مراد مختار. هتقعد ايه والله؟ ده اللي جاي.
صلاح ايتال. Okay, so next question. By what mechanism does antidiuretic hormone facilitate the reuptake of water from tubular fluid?
It will act by active transport by acting on antidiuretic hormone receptors in distal convoluted tubule, leading to transportation.
Sorry. I'm asking about the reuptake of water.
Yes.
You said
yes.
active...
I'm going for this. After this, it led to transportation of aquaburins from cell to the membrane. This is act as a water channel.
So
yes.
this is the mechanism. What you are saying now, this is the answer. This is the mechanism. Insertion of aquaporins. Okay.
Yes, insertion of aquaporins as a water channel. This transport solute-free water.
Yes. Okay. So the first part was not relevant. This is the answer.
Okay.
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 Why does water cross from tubular fluid into tissue renal medulla?
Because of the difference between the osmotic pressure which is high in the tubular fluid, high osmotic gradient between the tubular fluid and medullary tissue.
Yes, great.
Yes.
This is the answer, right? Okay. What is the process by which the medullary tissue becomes hypertonic?
At the first, at descending limb, it acts as permeable to water, but impermeable to solutes.
That's
So
right.
water move through the tubules into the medullary space, making the filtrate hypertonic. Okay.
Yes.
After this, sodium is actively transported out at the level of thick ascending limb. Yes.
Yes. Right.
It is impermeable for water. Okay.
Great.
The osmotic gradient between both. This is making the filtrate hypertonic, and the counter current mechanism between descending and ascending increase or multiply the osmotic gradient between both, leading
Yes.
to this action.
Yes, great. You're right.
ما تبدا وتقول الاول كاونتر
بالظبط. يعني هو
يا
البروسيس
كامل يا كامل مش عارف تقولها يا شيخ، ده انا قاعد مستنيك
يعني
قولها يا
yes and
يا
I
اخي ما
was
تتكلم
waiting.
يا
صح. You mentioned that all right and you said at the end, but it's better to start with saying the process is the counter current multiplier mechanism which occurs as follows and then explain.
Okay.
عشان الاكزامينر to be relieved from the start يعني.
ماشي خلاص هنعملها.
Okay.
خلاص انت صح.
But you said it perfectly يعني.
Yes,
How
you
does
explained it properly. You explained it properly.
yes. How does aldosterone act to maintain circulating volume?
It acts on the stimulates by the uptake of sodium by acting on the receptor at the junction between the collecting duct and distal convoluted tubules.
Yes, great. And can you please tell me what are the actions of angiotensin 2?
Me?
You.
Hello?
لا. Yes, the
Oh.
one. Yeah.
Yes. How does the angiotensin is the most potent vasoconstrictor in the body? It's released and activated according to angiotensin aldosterone system due to hypovolemia or increase in osmolarity of the plasma, leading
Yes.
to
And what are its actions?
Vasoconstriction of blood vessels.
Yes.
And stimulate give some impulses to the brain to decrease sensitivity to baroreceptors and increase the water intake by brain, and in the kidney they increase sodium hydrogen exchange, so increase sodium reabsorption and activation of aldosterone to increase potassium excretion in replaced with sodium.
Okay, so just to recap, you said it right. So it's a vasoconstrictor. It acts on the kidney to increase the sodium reabsorption. It stimulates the release of aldosterone. Okay. And yes, and it increases water uptake. Okay. Great. You said it right, but just to recap. Okay. Well done. You have done very well, both of you, in a very difficult station, as Dr. Salah said. So thank you very much.
regarding of the process when you will tell counter mechanism, no. يعني like Starling law, if you will tell Starling law, this is very famous and common, you should know it in physiology. Counter mechanism also, this in part A. So this is not you are keeping. You know the process to keep this is named counter mechanism, which is doing by 1, 2, 3, 4. So don't worry from this. But blowout is different. It's different. تمام؟ يلا.
لان بلو اوت دي يعني احنا we have searched to find that يعني it's not easy يعني.
كاونت ده عادي انك تقول يلا.
Okay, so next. Okay. We have Ahmed Ali and Rami Salama. Okay. Okay, Rami. Okay. And we have Ahmed Ali. Can't see him. طيب. Okay, so مش عارف. Okay. Okay. Good evening.
Good evening, Dr. Murad.
Hello, Dr. Murad.
How are you doing? Okay, so let's start. 50-year-old female presents with persistent discharge just above the umbilicus following an exploratory laparotomy with adhesiolysis and resection anastomosis of small bowel done for acute intestinal obstruction. So, sorry. Our first question, what's your diagnosis?
For me or Dr. Ahmed?
Anyone can start and the other will take the next question. No problem.
Okay, I
So,
think
okay, so you ask it, so you go first.
okay, I think the diagnosis is enterocutaneous fistula.
Okay, great. So next question, can you please tell me what's the definition of an enterocutaneous fistula?
It's abnormal tract between the gastrointestinal tract and the skin, which is lined by granulation tissue.
Okay, so it's abnormal communication between the skin and the gastrointestinal tract. Okay, great. Can you tell me how fistulas are classified?
There are multiple classifications for fistula as anatomical according to the site of the fistula. Physiological as high output and low output fistula according to the amount, and congenital or acquired fistula. Etiological cause, the cause of the fistula, if it's a surgery or trauma or any other thing, can be simple or complex fistula, can be internal or external fistula.
Okay, great. What is the most common cause of enterocutaneous fistula?
The most common cause of enterocutaneous fistula is distal obstruction. Distal obstruction.
How intestinal obstruction can cause a fistula?
How intestinal obstruction causes a fistula is distal obstruction. Distal obstruction causing increasing the intraluminal pressure leading to fistula formation. Yeah, I do not.
So any patient with intestinal obstruction, even in your practice, it comes presenting with a fistula?
No, actually no.
So you mean obstruction in the presence of other factors like anastomosis, intestinal anastomosis. Okay, so the most important, you have to start with intestinal anastomosis, then mention the other causes.
Okay. Intestinal anastomosis, malignancy, cancer, or Crohn's disease, or infection.
Yes. So iatrogenic like. So to simplify it, always it's iatrogenic like anastomotic leakage following anastomosis, inflammatory like inflammatory bowel disease, infections, malignant, as you said, cancer, or ischemic. Okay, so what are the predisposing factors for a fistula?
The predisposing factors, as mentioned now,
Yes, they
the
are the
causes or
same.
yeah, ischemia, irradiation, infection, intestinal anastomosis, Crohn's disease, or cancer.
Yes. Okay. What are the complications of anterocutaneous fistula?
Complications of intracutaneous fistula leading to malnutrition, fluid and electrolyte disturbance, or sepsis.
Yes, great. Okay, next question. What could bring a patient with anterocutaneous fistula to the OR?
If there is a distal obstruction or intra-abdominal sepsis.
Okay, great. If the patient developed nausea, vomiting, swelling, pyrexia, abdominal tenderness, and rigidity, what's your diagnosis now?
It's peritonitis, intra-abdominal sepsis.
Yes, perfect. It's peritonitis, most probably caused by intra-abdominal sepsis. Okay, great. How would you manage this patient initially?
I would manage this patient according to the care of critically ill surgical patient protocol. I will assure his airway is patent, his breathing is good, and according to the circulation, I will check the vital signs, the blood pressure, the heart.
After this, what are you going to do?
I will check the sepsis 6, which composed of high flow oxygen
Yes.
for the patient.
Great. Okay, this is part of a known protocol for managing the fistula. Do you know the name of this protocol?
I think it's SNAP protocol.
Yes. It's by the way, it is not for you to remember. It's written in the books. It's called SNAPs. So you have to mention it. It's written in the CRESP manual. Okay? So you have to say, yes, I will apply these SNAPs principles and mention them. As you said, you started with sepsis control, with sepsis 6. What else? What are the other components of SNAPs?
The nutritional assessment and giving the patient if high output fistula, more than 500 milliliter per day, we will give him total parenteral nutrition or intravenous fluids if there is a low output fistula. We will search for the anatomical assessment. We will do CT abdomen with oral and intravenous contrast to diagnose the site of the fistula and the exact location and extent. We will give him adequate fluid and electrolyte correction. Also, we will protect the skin.
Yes, you are doing great, but I just have one comment. I told you SNAPs, and you have to mention them like this. SNAPs, I will do sepsis control by applying the sepsis 6. For nutritional support, I will do anatomical assessment of the fistula. I will give fluids, and the other S is skin protection, and I will plan for surgery like this. So you have mentioned rapidly all the items. Maybe the examiner will ask you nutritional support. How would this be done? Then you have to elaborate more. Okay.
Yes. Excellent.
So you just mention the SNAPs like we said. Then you can elaborate after this.
Not to consume time. Yes.
Yes. For example, you may have said all the items and the examiner is just waiting or just looking at you. So you will start to elaborate more. Okay. So how would you manage nutrition in such patients?
I will manage nutrition of such patient according to the output of the fistula. If it's high up to fistula, I will consider total parenteral nutrition.
You will do it by yourself, or you would like to consult someone?
I will consult a dietitian first.
Okay.
According to the body weight, and he will decide the amount of energy for the patient.
Yes.
Okay.
Okay, and as you said, if it's high output fistula, most probably the patient will need TBN. Okay.
Okay.
Great. When would you consider surgical correction of an enterocutaneous fistula?
If the conservative treatment doesn't, if the fistula doesn't close with the conservative trials, if a failure of conservative trial.
Yes. What else?
Also, what else ongoing, or
what are the other indications? So you said failure of conservative treatment. What? Sometimes you can't wait.
Yeah, sepsis, intra-abdominal sepsis, or bad general condition of the patient.
Yes, if the patient has peritonitis, severe peritonitis with sepsis, you can't wait. Okay.
Yes.
Great. What are the factors that could prevent a fistula from healing spontaneously?
Presence of distal obstruction,
Yes.
malignancy, previously irradiated bowel, malnutrition, and inflammatory bowel disease like Crohn's.
Yes, great. And it's perfect, but if you can classify them for patient factors and local factors, it would be much better. Actually, do you like this classification? Local, as you said, infection, radiation, malignancy, obstruction, patient factors like malnutrition, okay, anything about the patient condition, okay?
Yeah.
So, what are the radiological modalities that can be utilized for assessing an enterocutaneous fistula?
I would like to do CT abdomen and pelvis with oral and intravenous contrast to detect the exact site and the location of the fistula. Also, we can inject water-soluble contrast in the fistula site to detect its connection to underlying structure.
Yes. So CT, as you said, CT abdomen with contrast, and this is the preferred method or the gold standard, and fistulogram. Okay. Thank you very much. This is the end of our station, and you did very well. Dr. Salah, do you have any addition?
You are the one who did very well, دكتور مراد.
نعم.
لا انت عملت شغل جامد في اللجنه دي. طيب انا عايز ارجع لحاجه في الفيستولا. يلا رامي معايا تاني.
يا باشا.
What is the non-surgical therapy for management of fistula, intracutaneous fistula?
Non-surgical, I will try to first resuscitate the patient and give him NBO, and we'll start a trial of total parenteral nutrition.
What else? Non-surgical management. Non-surgical management.
As we said now.
Snap.
يعني we have discussed
Yes.
this. Yeah. And sorry, Dr. Salah, just yes, in the 10th edition of CRESP, it's called SNAPS with another S at the last.
Skenosepsis. Skenosepsis.
Yeah, yes. So it's SNAPS.
Okay. This station came in Edinburgh last May in Edinburgh. Okay, in UK. The feedback for this station exactly like our mock, and they told me that examiner not satisfied about non-surgical management and when we'll go for surgery. For me, I searched and I shared for you the link already from Medscape. I shared link everything about intracutaneous fistula. Read it. Read it. What I should read from this? What the link I showed for you? Just management of fistula. I want you to know it. So, and I make it simple for you that the principles of non-surgical therapy for fistula: rehydration, NPO, good rehydration or IV fluids, administration of antibiotics after discussion with microbiologist and according to the hospital policy, correction of anemia if present, correction of electrolyte if disturbed, drainage of abscess if present, nutritional support, fistula control of fistula drainage, very important, and SNAPs, which is sepsis control or management according to sepsis 6 and skin protection.
دكتور صلاح معلش انا عندي بس سمول كومنت على sepsis 6 في sepsis control. Sepsis control also it means drainage of any infection. Okay, يعني in sepsis control in this algorithm it means also, and it's very important, is to drain any source of infection or control any source of infection. Okay.
Okay, so I wrote the titles. I shared the paper for the titles because they are not satisfied about non-surgical. So from Medscape, this all what is written. Okay, then you will go for the surgical therapy. Again, another question asked by Murad: when you will go for surgery?
Failure of conservative treatment or sepsis or peritonitis.
What else? Okay, what is it in Medscape? Patient who has fistula with adverse factors may require earlier surgical intervention. These adverse factors include the following. طبعا failure of medical, number 1. Number 2, lateral duodenal or ligament of fistula. يعني some areas of fistula. يعني don't tell about this. You have some area of fistula like lateral duodenal or iliac fistula or high output fistula. They should go for surgery. And if complicated fistula, complicated by bowel disease like distal obstruction or eversion of mucosa or sepsis. Tamam? Because it's not specified when you go for surgery about distal obstruction and sepsis only. So we added also some fistula should go for surgery directly according to their site. ماشي. I shared the link. I shared the link from Medscape. يعني when you are free, just read it. يعني to take ID. To take ID. تمام.
يعني to confirm, I'm just برضو checked CRISP again. It's in sepsis to obtain adequate drainage of any infection in sepsis in the S. Okay, so next we have Mansour Kamal and Aya Nasr.
وفي المانجمنت نسيت اقول لكم حاجه في الكونزرفتيف مانجمنت don't forget patient has much secretions. I can give octreotide, some medications. tell about medications like octreotide. تمام.
Okay, so we have Mansour and Aya.
ومعزين بريك. احنا فضلنا كام لجنه؟
فاضل لنا 4. Okay. Well, we will choose station. Okay. Okay, so we have a 50-year-old male patient with abdominal pain and bloody diarrhea. His vital signs are blood pressure 90/60, his pulse 130 beats per minute, temperature 38. After admission, had additional episodes of bloody diarrhea, which stopped 6 hours later. Initial resuscitation done with IV fluids. Lab results showed hemoglobin 8.8 and platelets 660,000. White blood count was 12,000, sodium 120, potassium 2.8, C-reactive protein 100, and he has high creat and urea. So first question, Aya, you can answer. What can you see in his blood picture?
I can see anemia
thrombocytosis, leukocytosis, electrolyte disturbance in form of hyponatremia, hypokalemia, increased C-reactive protein.
Okay, I asked about the blood picture only.
I'm
Okay.
sorry.
Okay. Thank you. Okay, so Islam, what is the type of anemia in this case?
Most likely it's microcytic anemia.
Okay, because this is chronic bleeding, microcytic hypochromic. Okay, what's your comment on his platelet count, Aya?
Thrombocytosis.
Okay. And what are the causes of thrombocytosis in this patient?
It's maybe because the state of inflammation or because the dehydration.
Okay, great. Cause platelets or thrombocytosis is acute phase reaction. Yani high platelets themselves are acute phase reactants. Okay, so we have done abdominal X-ray. Okay, can you see it? I'm sorry.
Yes.
Okay, so what can you see? Can you explain the findings in this X-ray?
All that I can see is distension of large bowel, mostly descending large bowel, and thumbprint sign, I think.
Okay, what do you mean by thumbprinting?
Okay, it's edema in wall of the large bowel in presence of the normal hostration, so give the impression of thumbprint.
Okay, great. Okay, next question. What are the common causes of bloody diarrhea in general?
Yeah, it could be because the inflammatory bowel disease. It could be because the ischemic colitis.
So
because
inflammatory, like inflammatory bowel disease, perfect. Ischemic,
yeah,
like ischemic colitis.
yeah, it could be because of cancer.
Yes, malignant. Okay.
Yeah. It could be also because amoebic colitis, radiation colitis.
Okay. Great. So you said all right. So we have also infective. So you said inflammatory, infective, like what? Amoebic colitis, dysentery, Campylobacter, or Clostridium infection. So as I always say, just classify to remember inflammatory, infective, neoplastic, which is malignant. Okay.
Okay.
In view of blood loss and hypotension, would you give this patient blood?
If it's a chronic, no, I will not give, because hemoglobin should be less than 7 in chronic blood loss. But if it's acute, I will, because less than 9, I will give.
Okay. So, do you have any other reasons of not giving blood to this patient?
Clinical sign of a stable or not?
The patient has fever, has leukocytosis, and what does this signify? Yes, the patient. Yes, great. Thank you. What has caused the mentioned electrolyte disturbances in this patient?
Most likely because diarrhea.
Okay, so there is loss in the diarrhea. Okay, thank you. Apart from these lab tests and X-ray, what are the other tests you would like to request in this patient?
Other lab tests, I may ask for serology, ANCA and BANCA, and may ask for tumor marker, carcinoembryonic.
Okay, what are ANCA and BANCA?
It's a serology for inflammatory bowel disease.
Yes, it's
anti-sarcomere cervical antibodies.
Okay. You have, I mean, always you have to know what does this stands for. Okay, you may become asked to mention it. Okay.
Okay.
So you have to know the short and the explanation of the word. He will always ask you. Okay, so you said serology. What else?
Tumor marker, carcinoembryonic antigen in case of its cancer.
Okay.
I may ask for stool analysis, culture if it's infective, and fecal lactoferrin or calprotectin in case of inflammatory bowel disease.
Okay.
And okay, I may ask for imaging like ultrasound, CT with triple contrast with gastrographene, enema. May ask CT enterocolonography and colonoscopy and taking biopsy.
Okay. Perfect. So you said laboratory. Perfect that you classified laboratory, radiological, and endoscopy. Okay. How would you know that patient is improving?
The first thing, the fever will settle down and the frequency of the area will decrease. Also, the WBC count will decrease, and CRB count also decrease.
Okay, so perfect. But you can say that I will know by the improvement of the clinical signs of the patient and also improvement of the laboratory results. And you mentioned what you said already. Okay. If the cause of diarrhea was inflammatory bowel disease, when surgical intervention would be an option?
We may consider it a failure conservative management or case of complication. Complication as toxic megacolon, perforation, continuous bleeding, malignant transformation, may if intestinal obstruction, fistula formation, abscess formation.
Okay, great. So refractory and complicated cases, as you said. Thank you. Okay, so what the procedure would be of a choice in this case?
This is depend on the patient situation. If the patient came by severely inflammation like
I mean, in this case, the patient has severe bleeding uncontrolled. Yes, what would you like to do?
Yeah, proctocolectomy.
In the acute situation, you need to do the least.
That's what I want to say in the first, that because
but I asked you, yes, that's why when I asked you, I told you in this case
we will do abdominal subtotal colectomy or abdominal colectomy.
Yes, for what? With what?
With ileostomy.
Yes, great, perfect. And you can say what you want to say. In if it's a chronic case or elective case, what would you like to do?
Proctocolectomy with ileal pouch, anal anastomosis.
Okay, great, perfect. Thank you. This was the last question, and you did very well, actually. Both of you.
لا مش حاسبها تعدي كده. دكتور آية.
أيوه.
What is the inflammatory markers you are doing?
حلو question ده.
Inflammatory C-reactive protein erythrocyte cementation rate.
What else?
What else? Acute phase reactants in general. What else?
Yes.
Platelet tumor necrosis factor.
What else?
I don't know more.
They like to hear some يعني one.
Interleukin.
Procalcitonin. This by the way, since long time asked الامتحان. طيب انا خايف من حاجه يعني every time they are telling procalcitonin ما هو مش ممكن حد يساله منهم what is procalcitonin.
لا صعب جدا صعب جدا يعني.
Anyhow, I shared some notes about procalcitonin. I shared some notes only few letters about what is procalcitonin because don't tell anything you don't know what is this. So okay يعني this is one of the markers, yes, early markers of the sepsis for any patient of sepsis. Yes, excellent. This one of the early markers who will aid to diagnosis of sepsis and how to be released or what is the stimulation for this to be done, like inflammatory cytokines, bacterial endotoxins, especially in sepsis, will be released. Mainly this is synthesized in the C cells in the thyroid gland. cells in the thyroid. Okay.
هو بروكالسيتونين يعني.
بالظبط كده من السيفلوكار سيلز. سو بي في ال لا سيب ده دلوقتي، ده حاجه ثانيه خالص. اوكي.
وفيرتين باي ذا واي از acute phase reactant. فيرتين also يعني to be known يعني.
But procalcitonin they like to hear this word by the way. يلا.
Yes.
نكمل.
Okay. Next we have Al-Shayma and Hiba. Raise your hands, please. Okay. Al-Shayma and Heba. Okay, they are here. And Shayma, Heba not here. Okay, Heba, please raise your hand. عشان احنا يعني we need to take. Okay, we can take Saeed. Okay. Good evening.
Good evening. I am with you,
good
Doctor.
evening.
Okay, are
Assalamu
you
alaikum.
ready? Alaikum salam wa
Yes.
rahmatullah wa barakatuh. Okay, so we can start directly.
Yes.
A 20-year-old motorcyclist has fractured his femur and tibia along with ecchymosis in the flanks, tenderness and pain in the lower abdomen with blood at the urethral meatus. The patient is pale, hypotensive and tachycardic. Shema, can you please tell me what other injuries would you suspect in this patient and how would you approach this patient?
Okay, first I will suspect bladder injury as the patient having a lower abdominal pain. We also suspect urethral injury as the patient having blood in the urethral meatus. And due to the patient having lungs, ecchymosis, we also consider renal injuries. Also with vascular injuries.
Okay, great. I liked your answer, by the way. Thank you. Okay, what's your first priority in managing a multi-trauma patient?
I'll follow advanced.
Okay, go on.
Go on, Doctor. Go on.
No, it's your turn. Go on.
Okay, I'll follow advanced trauma life support by at first clear airway, and here I'll be aware about spine, cervical spine, to immobilize it.
Okay, so your first priority, as you said, airway and cervical spine immobilization according to ATLS. Great, thank you. So if the patient's airway is secure and breathing and ventilation are fine, what's your next step?
I will assessing and managing the circulation using the pulse rate and blood pressure, capillary refill time, and clinical marker in form of pallor and peripheral warmth, level of consciousness. I will insert 2 wide port cannulae for drawing a sample for.
Okay, sample for what?
Examinations, ABG, and lactate level, preparing at least 4 cross-matched unit of blood.
Yes, great. So you have given the following X-ray. Okay, what can you see in this X-ray?
There is a disruption of sacroiliac joint with fracture pelvis and pubic diastasis or separation, which is, I think this is open book fracture.
Okay, what do you mean by open book fracture?
Pubic diastasis and disruption of sacroiliac joint.
Okay, so and this represents what kind of injury? I mean, is it lateral compression or vertical?
Yeah, I think this is AB compression.
Yes, great. So what are the types of pelvic fractures in general, Aya?
We can classify the pelvic fracture according to force applied to the pelvis into anterior posterior compression, lateral compression, vertical shear, and complex.
Okay, so as doctor said, the anterior anteroposterior compression is the open book fracture, and this is associated with most bleeding. And the lateral compression, I'm sorry, Dr. Salah, to explain this, is the closed book, okay? And it's more common. Okay, what is the type of shock would you expect in patient with fractured femur and pelvis?
It's usually hypovolemic shock and maybe neurogenic shock, but mainly hypovolemic shock, especially with femoral fracture.
Okay, don't say anything that would drag you into problem. Why neurogenic shock?
High trauma, because of trauma. The femoral fracture usually with high
Okay.
high trauma, yes.
Okay,
High
so in
pattern.
listen, in the AATLS manual, what are the causes of neurogenic shock? Is femur fracture one of the causes of neurogenic shock? No.
No, I'm thinking
No, it occurs in spinal injuries. Okay. And
Okay.
high in
And
cervical
also the
and the
patient is tachycardic.
high thoracic injury. No, but yes, of course. But cause I'm just saying, don't mention anything that would bring problems to you. Okay. How would you expect the pulse pressure to be in this patient? And what do we mean by the pulse pressure?
Me?
Yes, it's the same question. Continue.
Yes, pulse pressure, I think it may be more than 140. It is grade 4 of hypovolemic shock in this case with femoral fracture.
Yes, the pulse itself will be more than 140. Yes, but what is meant by the pulse pressure, and how would you expect the pulse pressure to be in these patients?
How would you expect the pulse pressure?
Yes, what is the pulse pressure first?
It is pulse pressure. It is narrow. It is the difference between systolic and diastolic.
Yes, great. And how would it be in this case?
It would be increase systolic. It will be narrow.
Okay. Can you explain why it would be narrow?
It would be narrow due to decrease systolic pressure, due to decrease effective circulating blood volume.
Yes.
And with increased diastolic blood pressure due to increased resistance, peripheral resistance.
Yes, due to increased systemic vascular resistance. Yes, great. Okay, how would you manage this patient's shock or hemorrhagic shock? Yeah.
I will start by applying of massive transfusion protocol. The patient lost more than 50% of
directly.
blood.
You firstly give the patient blood.
No, first I give the patient crystalloid, 1 to 1.5 liter.
Only one. Say one. Okay.
Okay.
And then
followed by blood.
Yes, as you said, massive transfusion. Yes.
And control the bleeding using a pelvic binder and external fixation. And if there is any suspicious of intra-abdominal bleeding, we're doing a laparotomy to control the bleeding.
Yes, perfect. Thank you. How can you say that this patient is improving?
By following the heart rate and capillary refill and blood pressure and urine output and conscious level and temperature. Six parameters bed test.
You are assessing the circulation now. We are focusing on the circulation, so don't mention temperature. Okay. You are very good, but don't put your touch, please. Okay. So we're talking about the circulation. To assess the circulation,
with improving temperature will be improved. Hypothermia due to hypovolemic will be improved.
Okay. But yes, you are right in general, but in this case, the patient is shocked. So focus on the items of assessment of the circulation. Okay. Okay. How would you confirm your suspicion? I'm sorry. If you find blood at the urethral meatus, would you still insert a Foley's catheter?
No, I will never do it.
No.
Okay, so can you tell me why?
Me?
Because the patient will have a urethral injury.
Yes, because there may be a suspected urethral injury. Okay, and you can answer. How would you confirm your suspicion?
You, doctor, go on.
You, I mean you.
Okay.
You does not specify male or female. I'm sorry.
Okay.
You
Okay,
can
okay.
answer.
Confirm suspicion
Yes.
by doing a histogram, maybe anterograde or retrograde.
Yes, perfect. Thank you. Okay, so what are the other pelvic organs that is commonly injured in open pelvic fractures?
The urinary bladder.
Okay, thank you. When to avoid inserting a Thales catheter in general?
In general, in case of metal stenosis or infection around the gland's penis or urethral trauma or pelvic trauma, and in case of presence of general condition like bleeding tendency.
Okay, great, thank you. Okay, what would you do if a Thales catheter is contraindicated? Contraindicated or failed, or catheterization failed? Both are the same, yeah.
I will consult for your urologist to put a suprapubic catheter.
Okay. Okay. Do you know other types of catheters?
Yes, silicone and straight and condom and suprapubic catheter and three-way.
Okay. Thank you. How would you manage a pelvic fracture?
Me?
No, it's her turn. Guys, focus, please.
Okay. I will start by applying a pelvic binder and giving patient IV tranexamic acid and ordering a CT with IV contrast. Backing external fixation.
Okay, so you will apply a pelvic binder. What else? You said you give the patient tranexamic acid, right? Okay.
And if there is active bleeding and not response to suspicion, we doing surgical backing
or
interventional radiology.
Yes, great. And what else can we do?
Also, in the case of displaced vertical shear, we're doing traction.
Yes.
And in the cases of peritoneal hematoma, or affection of gryon or anus, we consult the colorectal surgeons.
Yes, great. You said it right. Okay, and we said after resuscitation, again, after the initial resuscitation, according to the ATLS, we will do these items. Okay.
And the call for help برضه يا باشا ولا ايه؟
We always call for help يعني بس يعني in the ATLS in any ATLS station you will call for help and you will prepare your team and you will apply universal safety measures, but يعني this is time consuming. Just mention I will do ATLS, then mention these items, okay? But of course we will call for help يعني بس ده in any ATLS, but you don't have to say it every time يعني. Okay, would you order a whole body CT for this patient and why?
Yes, I'll order for him as it is bullet trauma for early diagnosis, and it will improve survival rate and give me an idea about exact location of trauma and the bleeding if it present.
Yes, perfect, right. But يعني mention it's a high energy trauma.
High energy.
Oh. Okay. So, okay, perfect. Yeah, thank you very much. This was the end of our station. Dr. Salah, any comments?
This station came once. Since that time, not came before. Since that time, since long time, about maybe 3 years. And coming by this way, okay? He's concerning especially about catheterization. both for catheter for any patient suspected pelvic rupture. Not acute. Okay.
Okay. Right. Okay. Next we have Menaim and Zunaina. Okay. يعني أنا مش عارف why they are not raising their hands. Okay, we have Farheen and
Hello.
yeah. Hello.
Assalamu alaikum.
Alaikum salam wa rahmatullah. How are you doing?
Great, thank you. How are you?
I'm fine. Okay, we have Nidal also. Okay. Okay, Nidal, are you here?
Yes.
Okay, welcome. So we can start. Okay, a 20-year-old male patient, his leg was crushed for a few hours. The patient was left unobserved in the orthopedic ward. Blood showed increased creatinine, increased urea, and urine dipstick was positive for blood. Okay, we have a noisy background. Okay, it's better now. Okay, Nidal, can you tell me what complications would you expect in such a patient?
This is could be compartment syndrome or rhabdomyolysis.
Perfect. Next, how would you suspect compartment syndrome?
According to the clinical picture, if it's compartment syndrome, there could be worsening of pain and paresthesia. There are some signs like tense and swollen compartments, sensory loss, pain on passive stretching, and if it's late, we may found loss of regional pulses.
Perfect, thank you. It's important that you started your answer with clinically. I would suspect it clinically, and then you mentioned the signs and symptoms. Thank you. The patient sustained spinal cord injury with complete loss of motor power and sensations in his lower limbs. How would you confirm compartment syndrome in this case? And is okay.
Yes, by major intercompartment syndrome, if it is the exceed 30 millimercury, that is the mean decrease in blood flow and injury in the nerve and muscle, and also measure blood systolic blood pressure. If this decrease, this is also mean there is compartment syndrome, and
I just need to explain this point. By measuring the blood pressure, it means that when there is a low blood pressure, this increases the chance of compartment syndrome, but it's not a sure sign, okay?
Okay.
Okay, so, and is this measurement of compartment pressure necessary to diagnose compartment syndrome?
Yes, it's necessary.
In every patient, we need to measure the compartment pressure?
And just in this patient because loss of the motor power and sensation.
Yes, thank you. Perfect answer. Not in every patient, because it's mainly clinical suspicion. Okay.
Yeah.
So what is the normal compartment pressure?
It's a 0 to 15 millimeter of mercury.
Okay, perfect. What would be your action if you clinically suspect compartment syndrome in the leg?
This I will do fasciotomy.
Okay. How you would do it?
We do 2 incisions, one in the anterolateral and one in the posteromedial.
Yes. So we do 4 compartment fasciotomies with 2 incisions, as you said, anterolateral and posteromedial. Perfect. What will you discuss with the patient before fasciotomy?
If a patient's mental status is all right and he is capable to understand the situation, I need to discuss about the operation and the upcoming possible complications like permanent nerve damage, permanent muscle damage, scarring. There could be a loss of limb and a possible infection, renal failure, And in rare case, death also can occur. I need to discuss these things with the patient.
Yes. And when you are saying loss of the limb, you can say, I will clearly consent the patient for the possibility of amputation. Okay?
Okay.
Do
Okay.
you like the word amputation? Okay.
Okay.
Thank you. Perfect. Okay. What are the other areas of the body susceptible for compartment syndrome?
The abdomen.
Okay. So abdomen and the lower limb and also the upper limb, it may occur in the forearm. Okay.
Yeah. Yeah.
Okay. From the patient's history and kidney function tests, what do you think happened and why?
I think patient is undergoing for acute kidney injury. It's because of the nephrotic effect of the myoglobin. If the myoglobin precipitated into the renal tubule, it gives some kinds of toxic effect and produce cast which occlude the renal tubules. Also, there is vasoconstriction, which resulting decreased extracellular volume, and all the myoglobin casts and the vasoconstrictions, all of them resulting renal tubular ischemia and necrosis. So this patient may undergoes for acute kidney injury by this pathology.
Yes, perfect answer. And if you want to make it more perfect, you can say pre-renal due to decreased extracellular volume, okay, as you said, and renal due to the nephrotoxic effect of myoglobin, and you continue your answer, okay? This will be much better. Okay, the patient developed severe muscle pain and dark amber red urine. Investigations revealed a high creatine kinase levels. What's your diagnosis now?
This is rhabdomyolysis.
Okay. Can you define rhabdomyolysis?
Release of potentially toxic muscle cell components into the systemic circulation.
Okay. And what's myoglobin?
It's a muscle protein which found in the muscles, and it usually acts
Which
like an
type of muscle?
skeletal muscle.
Striated muscle, which
Striated.
includes skeletal and what else? Cardiac muscle.
Cardiac muscle, yes. Thank you.
Yes. Okay, perfect. Okay, so what are the known causes of rhabdomyolysis?
Yes, so we have many causes of the rhabdomyolysis, like blunt trauma in the skeletal muscle. Also, in the case of the massive burn, prolonged immobilization, and also hypothermia, hyperthermia, and drugs like alcohol, cysteine.
There is a very important one.
Fibrates.
Okay, what happens after ischemia when there is ischemia? There is a phenomenon that occurs with ischemia. Reperfusion, ischemic reperfusion injury. Okay, it's important to mention this one. Okay.
Okay.
So what is the definition of reperfusion?
This is the next question. Okay, what's the ischemic reperfusion injury?
I'm sorry, can I pass this question? I just forgot.
Okay. Okay, you can answer.
Yes, reperfusion is a paradoxical augmentation cellular death caused by reperfusion.
Okay. Yes, which is the restoration of the blood. يعني explain reperfusion. It's the restoration of the blood flow to the previously ischemic port.
Yeah.
Okay.
Okay.
What are the expected laboratory findings associated with rhabdomyolysis?
If according to the biochemical test, if we check the enzymes, the creatine kinase will be increased, which is about 5 times than normal. And we can check the serum lactate, lactate dehydrogenase, and creatine. All of them will be increased. In case of electrolyte, we will found that potassium, phosphate and uric acid, all of them will be increased, but calcium will be decreased. And we will found myoglobin in the urine routine examination.
Yes, great, thank you. Okay, how would you manage this patient?
Yes, I will manage this patient according to advanced trauma life support ABC. Start by good hydration till urine output be more than 300 ml per hour. Then this is for crystalloid. Also alkalization of the urine by sodium bicarbonate. Alkalization of the sodium bicarbonate.
Okay, you are doing great. What else? You
Also,
assess the ABC, you give
yeah.
fluids, alkalinization of urine. What else?
Also, there is the diuretic like mannitol use there. Also treat electrolyte disturbance.
Like what? What is the most serious one?
This is hyperkalemia.
Okay, how would you manage it? In the exam, he will ask how to manage hyperkalemia.
Firstly, by monitor the patient.
Yes, cardiac monitoring, especially. Okay, then.
Then I give patient. Okay, no, this is calcium. This is no.
Yes, you are right. By the way, go on.
I give patient glucose, calcium gluconate. I will give patient.
Yes, this to stabilize the heart. Okay.
Yes, also give patient salbutamol because it shifted the calcium from the to intracellular.
Yes, what else, which is very important?
Insulin drip.
Yes.
Insulin and glucose.
This is very important. So as you said, to recap, it's right. We give calcium gluconate to stabilize the heart. Then we give insulin, okay, in dextrose, and we give salbutamol, okay. We have to know it in details because it's present in another station, okay.
Yeah.
And we will monitor the labs of the patient and the vital signs, okay. And if the patient needed fasciotomy, we will do fasciotomy. Okay, this is very important in the treatment. Dr. Salah, there was some confusion about ATLS or CRESP, but anyway, it's mentioned in CRESP in ATLS. If it's traumatic and the patient presenting in the emergency, we will address the patient according to the ATLS. But this patient, if the patient was in the ward and this occurs in the ward, we will approach the patient according to CRESP. A safe way to say it.
CRESP mainly according to the parameters, early modified score. So this will not be in the street. This will be in the ward. So CRESP, you are doing CRESP for which patient after looking for the warning signs in his chart, and this is not in trauma. So any patient in the ward with a chart with
yes. And a safe option in any other station, or if you got confused, say I will manage the patient according to the principles of A, B, C, D, E. They are the same. Okay. So thank you very much. You did great. Dr. Salah, any comments?
She has another question. They will ask about management of hyperkalemia in this patient in details, and you did. So you told in management alkalization of the urine.
Why?
Oh, it will increase pH of the urine, which will prevent a cast formation by myoglobin in the acidic urine. And it also shift potassium from the extracellular fluid to the intracellular space. And it also increase urinary excretion of excess potassium.
Yes.
Increasing pH itself by alkalization of urine, increasing pH.
Yes.
This will enhance potassium to be shifted from extracellular to intracellular, so decreasing.
Yes, she answered. Perfect.
Yes. Increase also pH more than 7.5 by alkalization. This will prevent reabsorption from urine so will enhance urinary excretion of potassium, so will be decreased also. Plus, it will prevent casts from toxic metabolites of myoglobin in acidic urine. This third one, he's waiting this answer. Okay.
Okay.
Great. Yalla.
Thank you.
Okay, so our last station we have Abdurrahman Ali and Farheen again. So does anyone wants to participate?
Go for notes group side. I wrote it in the notes group. كانت لك بالتفصيل في النوتس جروب.
ايه اللي في النص جروب؟
الرول اوف alkalization of urine.
Okay. So okay, we can choose Hussein. Okay. Who else? And with it. Okay, are you here?
Yes, I'm here.
Okay, great. Mustafa, sorry. Mustafa, he didn't participate. So we can unmute Mustafa. Mustafa, are you here?
Hello.
Hello. Welcome.
Welcome.
Okay, so we can start our station. Okay. We have a 50-year-old male smoker with a long history of non-steroidal use for osteoarthritis, presented at emergency and with acute onset abdominal pain in the epigastrium. On examination, there was abdominal tenderness, rigidity, and infrequent bowel sounds. What is the most probable diagnosis of this patient?
So most probably perforated peptic ulcer.
Yes. Yes. Most probably it's a perforated viscous, and considering the history of the patient, okay, it's mostly a perforated peptic ulcer. Yes, right. Yes. Okay, so we have done X-ray for this patient. Okay, can you see it?
Yes.
With that, are you here or what?
Yes, yes.
Okay, you can answer.
Okay. This is just
can
X-ray.
you? Okay, can you please comment on it?
It is chest X-ray posterior anterior showing air under right dome of the diaphragm.
Okay, and again, say I will check the patient. Yes,
yes.
I will check the patient details and the date. Okay, great. What are the risk factors for perforation of a peptic ulcer?
So non-steroidal.
Here, according.
Sorry.
Okay. According here, because to the case, the patient is taking non-steroidal anti-inflammatory drugs. So it's a mostly probably the risk factor here, and also there's other risk factors like taking steroids
and the patient
smoking.
is also smoker.
Smoker.
In the stem,
Also
yes.
smoker.
So what are the other risk factors in general? You can answer, Mustafa.
Yes, steroids, history, H. pylori infection, history of previous peptic ulcer or
Yes.
malignancy.
Yes, great, thank you. Okay, with that, how can the use of non-steroidal anti-inflammatory drugs promote ulcer perforation?
It is kind of caused by many mechanisms. First, it can topically it is topical irritation for the mucosa of external gastric mucosa, and also it can decrease gastric mucosal blood flow, and also can reduce prostaglandin synthesis by inhibition of cyclooxygenase, and
Which
also
one? Which cyclooxygenase?
Two
or one?
One.
Okay, so go on.
Interfere with repair of the superficial injuries.
Okay, great, thank you. How would you manage this patient initially? Hossein, you can answer.
First, this patient, initially for this patient, I will management according to care of critical ill patients by giving a check airway with breathing, but mostly check the circulation for this patient and by starting resuscitation. This is initially, and I will go for definitive management for him.
Okay, you give the patient, which kind of fluids would you give to the patient?
He's a patient, I will give him crystalloid fluid.
Okay, so, and you will keep him in BO. Okay, you have to say this also. Okay, and you will give him proton pump inhibitors. Okay. Okay, so after resuscitating the patient, what else would you do?
So patient, I will go for exploration.
Yes.
Mental repair, peritoneal toilet, and intra-abdominal drain. I will take biopsy to exclude malignancy.
You will take biopsy from every ulcer?
Yes, to exclude malignancies.
No, only in gastric ulcers.
Okay.
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 Perfect. Okay. Do you know the meaning of NCE bot? وداد.
Yes, it is national.
Disappeared.
Not disappear. I'm here. I'm waiting you to finish the question only.
Okay.
This is abbreviation for National Confidential Inquiry into Patients' Outcome and Death. Classify the operations into immediate.
Yes. Mention the classes. What are they?
There are 4 classes: immediate, urgent, expected, and elected. Immediate for life-threatening conditions and organs like organ saving, and just like a perforated abdominal aortic aneurysm. Ruptured aortic.
Okay, so you know them.
Syndrome.
Can you tell me this operation, how it's classified according to the NCE book?
It is classified according to the time of operation, when we will do the operation. For
okay,
immediate,
so this operation, a perforated peptic ulcer, is it immediate or urgent or what?
Perforated peptic, it is urgent.
Okay, perfect, thank you. What medication would you give this patient post-operatively? Hussein.
This patient post-operative for the medication first, I will give him proton pump inhibitor, and keeping the patient MPO.
Okay, but for long term, you will give the patient proton pump inhibitors. Okay. Mustafa, can you tell me how does proton pump inhibitors work?
So it is irreversibly bind to hydrogen potassium methyl enzyme or proton pump that inhibit secretion of hydrogen. This hydrogen bind to chloride forming HCl. By this mechanism, we will prevent formation or decrease formation of HCl.
Perfect. Thank you very much. That most important, you mentioned bind is reversible. Okay, great. What are the physiological actions of gastric HCl? With that, you can answer.
It is activate pepsinogen to pepsin, and it had antimicrobial effect. Also stimulate the intestine to secrete CCK and promote absorption of calcium and iron.
Okay, perfect. Thank you. Hussein, can you explain the physiological process by which gastric HCl is released?
For gastric HCl secretion, there is three ways. First, cephalic phase.
Phases, yes. Okay.
3 phases. First, cephalic phase, it's about 30%, and this decrease is increased due to vagal nerve stimulation to the lower part of the esophagus and the stomach, parasympathetic effect, and also there's a gastric effect phase, which is 60% of the secretion due to distension of the stomach, and also there's an intestinal effect, also for 10%, and due to for the high acidity in the stomach.
Okay, and it's inhibitory phase, by the way. At the end, the other part of it, it's inhibitory. Okay. Great. Thank you very much. You three of all did very well.
Thank you.
Okay. Thank you.
Thank you.
Dr. Salah.
They did great. Regarding this station, he's asking the question about non-steroidal mechanism on COX, which is COX-1 or COX-2, the enzyme like we discussed before. So I told this in critical care. This question, ask it here. They asked the question here. Okay.
Okay. So any additional questions?
No. It's exactly by this way.
Okay. So I think Dr. Salah, they did very well صراحة. يعني.
لا النهارده كويسين، المجموعه كلها كويسه ما شاء الله.
يعني very well. انا بس يعني even الكومنتس اللي انا بقولها انا just trying to modify how we answer عشان البروفيشناليزم بس يعني they know the knowledge but we need just to modify the way we answer يعني.
Your way is exactly like examiner. Your way they are asking exactly like Murad asking. Okay, so please follow this.
Okay.
إن شاء الله. Thank
you will do great يعني I'm sure.
والله we are depressed because of result of Bahrain exam and we
أنا عارف الكلمة دي
no. This is a motivation يعني ده motivation.
المطلوب مني يا وداد، المطلوب مني ان انا كنت اسكت ولا انا عشان تعملوا براكتس عشان لما تجيبوا الهاندس اون في السعوديه تكونوا متدربين جاهزين. لا احنا جايين، احنا رايحين نوري شغلنا اللي هيبقى في الامتحان شكله ايه وهو يدينا الكومنتات بتاعته.
وهو على فكره كلام الدكتور صلاح ده والله العظيم بالظبط، لان هو الدور دلوقتي ان هو يديكوا فيدباك. يعني احنا المرحله اللي احنا فيها في الهاندس اون ان احنا فيدباك جيفرز خلاص. يعني احنا المفروض التريننج والنولج والكلام ده انتوا بتاخدوه through out the course، انما يعني
والله دكتور مراد احنا we are taking يعني we are strictly following your advice for you, for دكتورة سوزان, for دكتور صلاح, for sure, for دكتور شهادة.
يعني
we are following strictly and we are hoping to pass ان شاء الله.
ان شاء الله يعني. واحنا كلنا followed the advice. انا نفسي followed the advice of دكتور صلاح and دكتور سوزان يعني.
الله نلحقكم يا دكتور مراد ان شاء الله.
هقول لكم على I want before going I wanted to tell you some points. واحدة منهم آية ممكن تكون عارفاها يعني about سارة الباز. She went for UK. She joined the course 2 months only. She's not studying but she listened for everything and she went in UK and she passed in UK. This is number 1. Number 2 الضايع بتاعنا الباز افندي احمد الباز. احمد الباز I know this man since long time. In part A he joined me 2 weeks. Saved me by this way and he passed. In part B he did the same before exam by about 13 days only. Dr. Salah saved me like we did in part A. I said do not pass. Salah not by anyhow. I told listen for this mocks and no need to go for skills because you are in UK and you have no time. He followed this and he passed. He passed within 13 days. He didn't take courses. Okay. Third one, Muhammad El-Jazzar, friend of Sharif. This one he came for hands-on in Egypt last exam in August. This man when he started, when we are starting CRISP, he said I can do it. I said show me. He's not taking courses. Sharif told me this man who attended hands-on, he's not taking courses. Then I told show me. He started. He is confident. Like he started with the patient. Hello, my doctor is Ahmed El-Jazzar, one of the surgical doctors. Honestly speaking, for you, nurse told me he's talking by this way. أولاً ده جاي بالشرق غرب والغرب شمال ومبوظ الدنيا. But this man, his way in talking very nice, confident. Only that. I said to him, if examiner will evaluate according to your knowledge and your arrangement, you will fail. But with this confidence, you can manage it. This man attended hands-on, listened for the mocks and passed. Last one. She's Egyptian. I think you know it. You know her. تعرفاها كانت معاكم يا وداد. ماجدة. فاكرة ماجدة؟
ايوه ماجدة ما شاء الله نجحت. ايوه الحمد لله.
ماجدة what happened for her? Magda, she came hands on in Khamis Michel before going for Oman exam. When I told her I wanted to see you, show me in Khamis Michel. What she did? She did nothing. She has nothing in her mind. No professionalism, no communication, no information, nothing at all. And the exam after 1 month. I called Shnoda. I am after Shnoda to tell her, but she will not pass Shnoda. Contact her. Shnoda told her that. You know what she did in this month? She did practice. Shnoda told me about her evaluation in the exam. He said to me, she did great. She did great.
She passed, alhamdulillah.
She passed.
Yes, I know she passed, alhamdulillah.
How these people, they are passing the exam? How these people confident, smiling, getting examined, they are following. أنا هقول لكم بقى مشكلة. People who are staying with me for a long time in the course, they are suffering in exam. People who joined me only for 2 weeks or 1 month, they know the most important information, they are following and pass.
صح. This is important. صح. They are not lost in the details.
الله يطمنك يا دكتور صلاح.
لا انا عايز بس اقول small comment على كده فعلا explanation لوات دكتور صلاح said. In the exam, the examiner is just observing you. He's seeing if you are acting naturally with the patient, you are greeting the patient, you are smiling, okay? But if you know a lot of information, but you appear to be confused, not smiling, stressed, you will lose marks. And this is the explanation. يعني ممكن واحد ما يبقاش عنده معلومات كتير بس هو شكله يعني ستايل كده كونسلتنت وهو داخل على البيشنت، فطبعا ده بيفرق جدا. فيعني عشان كده مثلا احنا في الاكزامينيشن نهتم ان احنا واحنا بنعمل مثلا التست نعمله بشكل كويس، نبقى لطاف مع البيشنت، ما نعملش مثلا حركه عنيفه. يعني فاهمين قصدي؟ ومش مهم
شوي الباس صاحبك مربي شعره كده يا ابني، الباس ده لو شفته والله العظيم بجد انا قلت له يا ابني ما تكلمنيش تاني. and يعني he's my friend by the way, he's my Mr. but I know he's crazy. This man is crazy. So confident يعني Noba also was hands on only. She passed the skills. Even she told me I'm not listening for many things. Okay, الموضوع بسيط على فكرة. But what happened in البحرين lack of practice, communication, professionalism. بص مجموعة البحرين جم عند خميس مشاهد. They came in خميس مشاهد. I am pushing them. Anyone to please go. Anyone will do the examination. They are sitting. Hand examination. They are sitting. So I discovered the weakness now. I will not allow anyone who will come for hands on with me. I will start. Go do now. I will push all of you. Do now. We are five or six admins in Khamis Mashayikh. So all of us will start to push. And this is what we will do in all centers. That's what we'll do in all centers. ما عادش ينفع ان انت تيجي تتفرج. ما ينفعش خالص. Knowledge 100% you can pass it by this MOOCs. 100% you pass it by this MOOCs. Don't worry. Skills now our biggest challenge. Okay. And by the way, in Cairo, who are going for Cairo and UK, don't worry. It will be easy for you. تمام. RCSI, take care from these people. ماشي يا شباب، يلا نشوفكم على خير ان شاء الله.
شكرا يا شباب. Thank you everybody. شكرا دكتور صلاح. اوكي.
شكرا دكتور صلاح. شكرا دكتور مراد.
العفو. شكرا. good luck. باي.